The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day, everyone. This is Dr. Ronnie Baticulon, and today we will be discussing clinical cases in biochemistry. Kamusta ka na? So, I know these are very difficult times. No? Habang tumatagal, mas humihirap ang mga araw sa iyo. Bawat umaga, mas mahirap pumangon. Tapos, bawat gabi, mas mahirap matulog. Ang nakakabaliw pa nun, lahat ng ibang tao sa paligid mo, parang wala lang. No? Parang napaka-normal at napakasaya ng mga buhay nila. No? Ganyan talaga, no? Ganyan talaga. Gusto ko lang sabihin na naniniwala ako sa iyo. Kahit na sa totoo lang, ang kaharap ko ngayon ay computer at hindi naman talaga ikaw. Pero seryoso, ikaw talaga yung kausap ko. Kung gusto mo nang bumitiw, kung gusto mo nang sumuko, kung gusto mo nang ipagwalang bahala ang lahat, uulitin ko, naniniwala ako sa iyo. Naniniwala kami sa iyo. Naniniwala silang lahat sa iyo. Kahit na wala ka ng tiwala sa sarili mo. Okay? Tandaan mo lang kung bakit mo ginagawa ang lahat ng ito. Lahat ng papakapagod, pagpupuyat, at pagsasakripisyo. Ginagawa mo ito kasi alam mo na pagkatapos ng lahat-lahat, no? Pagkatapos ng lahat-lahat, mas makakapagsilbi ka sa mas maraming tao, lalong-lalo na sana sa mga kapwa natin na Pilipino. At mahalaga yon, no? Mahalaga yon. Sana sapat na yon para araw-araw mabigyan ka ng lakas na magpatuloy lumaban, no? So lagi ko nga sinasabi, give it your best shot. So give it your best shot when you know that you've given it all that you can. There will be no room for anger, frustration, disappointment, or shame, no matter what. No matter what. Okay? And I assure you, it will be worth it. It will all be worth it. Pag tapos na ang lahat, no, pagpasado ka na, pag may lisensya ka na, huwag kang mag-alala. Hindi mo na kailangan kabisaduhin lahat ng to. Pwede mo nang sabihin, phosphofructokinase, wala kang silbi sa buhay ko. Okay? So, let's proceed. So, as I've said, today we'll be going through clinical cases. No? So, if you recall, no? So the biochem final coaching session, no? Yung last session it's only about discussing the pathways. But here, what we'll be doing is we'll be doing it question and answer format. Okay, so we'll be doing question and answer format. Initially, just a review on metabolism concepts. We'll just do metabolism concepts. And then, but the rest of the session will really be about cases. No? So there are times kasi sa board exam, minsan cases talaga yung binibigay nila. So you need to be familiar with how to answer these questions. Again, I really have no idea what they will give in the board exam, no, this year. So pabago-bago kasi yan. There are times when they just give straightforward questions, but there are also times when they give cases. And even when you're given these cases, no, don't panic. No, don't panic kasi. So I will teach you how to approach these questions so that if they do come out, no, then you are not paralyzed and you will be able to eliminate the choices, so that increases your chances of getting the correct answer. Kung straightforward questions, edi good, di mas swerte, mas maganda. Okay? So once again, what I want you to do, no, so always remember, just remember these biochemical pathways, no. So remember the hypothetical cell. This is cytosol. This is the mitochondria. Your homework is that you should be able to tell yourself, no, ano ba yung arrow na yan? Ano ba ibig sabihin? Ano ba yung mga enzymes na yan? Ano ba yung mga pathways na yan? No? Nangyayari ba yan kapag well-fed? Kapag fasting? Insulin? Glucagon? What's the rate limiting steps? No? What's the rate limiting step? Yun lang naman yun. So just remember your 5 questions, di ba? Remember your 5 essential questions. Now, what we'll be doing here for the next 4 hours will be answering yung clinical correlates. So practice first. So what is the effect of high insulin on fructose 1,6-bisphosphatase? Is it activated, inhibited, or neither? What is the role of high insulin on the activity of fructose 1,6-bisphosphatase? Is it activated, inhibited, or neither? Sabi ko kahit na mag-isa ka lang sa kwarto, okay, you need to try to answer. Okay? It's better that you get the wrong answer now, no, then at least you know what's right next time in the actual board exam. So don't cheat yourself. No, don't cheat yourself. So let's go through this. High insulin. So kapag high insulin, are you well-fed or fasting? You're well-fed. No? You're in a fed state, first 4 hours after a meal. And then fructose 1,6-bisphosphatase, saang pathway siya? So fructose 1,6-bisphosphatase converts fructose 1,6-bisphosphate to fructose 6-phosphate. So this is in gluconeogenesis. No? Gluconeogenesis. So kapag well-fed ka, gusto mo bang mag-gluconeogenesis? Gagawa ba tayo ng glucose when we are well-fed? The answer is no. Kaya nga this is inhibited. So this enzyme should be inhibited in the well-fed state. Okay. Next question. What is the effect of low glucagon on hexokinase? Is it activated, inhibited, or neither? What is the effect of low glucagon on hexokinase? Activated, inhibited, or neither? So if glucagon is low, what is high? Insulin. No? So ibig sabihin, well-fed pa rin tayo. Well-fed pa din. We're still talking about the fed state. Hexokinase. Saang pathway si hexokinase? Hexokinase is first step of glycolysis. So in the well-fed state, what do we want to do to glycolysis? Do you want to break down glucose when you're well-fed? Yes, no. You want to break down glucose because in the fed state, mataas yung glucose. Okay? So dali lang, di ba? Next question. Low insulin glucagon ratio. Glycogen phosphorylase. Low insulin glucagon ratio. Glycogen phosphorylase. Is it activated, inhibited, or neither? So kung low insulin, high yung glucagon. So kung ang mataas yung glucagon, what state is that? So that's fasting state. No? Kasi mataas yung glucagon. No? So pag sinabing low insulin glucagon ratio, mas mataas yung glucagon. Glycogen phosphorylase. Do you remember glycogen phosphorylase? Anong ginagawa ni glycogen phosphorylase? Ay, di ba? Kagat. Okay? It breaks down glycogen. So glycogenolysis. So in the fasting state, gusto mo bang magkagat? Do you want to break down glycogen? Yes. No? You want to break down glycogen so that, for example, in the liver, you can provide glucose to the other tissues. High cortisol, HMG-CoA reductase. Activated, inhibited, or neither? High cortisol, HMG-CoA reductase. Activated, inhibited, or neither? So HMG-CoA reductase, is the rate-limiting step of cholesterol synthesis. It's a rate-limiting step of cholesterol synthesis. So now, what about cortisol? Sabi natin, if you see cortisol, think of glucagon. So si glucagon, may tatlo siyang kakampi. Epinephrine, cortisol, and growth hormone. Pag sila yung nakita natin sa question, think, what would glucagon do? So, para ka ding fasting. So, gagawa ba tayo ng cholesterol? Kunyari, fasting tayo? Or in this case, high cortisol means it's in a stressful situation. If you are in a stressful situation, gagawa ka ba ng cholesterol? Of course not. No? So it's inhibited. So parang di pag-fasting, di ba? Hindi ka gagawa ng cholesterol. No? So yung cholesterol, tandaan nyo, analogous yan sa fat. No? It's very similar to fat. So kapag active yung fatty acid synthesis, active din yung cholesterol synthesis. Pag inhibited, inhibited din siya. So parang pag stressful situation, di ba? Hindi ka na magpapataba noon, tatakbo ka na lang. That's why a high cortisol will inhibit your HMG-CoA reductase. High cyclic AMP, hormone-sensitive lipase. Is it activated, inhibited, or neither? High cyclic AMP, hormone-sensitive lipase. Is it activated, inhibited, or neither? So, what does hormone-sensitive lipase do? So remember, si hormone-sensitive lipase, anong ginagawa niya? Ginugupit niya yung, sino? Triglycerides. Kung meron kang triglyceride, gugupitin ni hormone-sensitive lipase yung mga fatty acids from the glycerol backbone. Okay, so tandaan nyo, yung mga lipase, ganun ginagawa niya. Like for example, si lipoprotein lipase, ganun din. Yung mga hatid na yung mga lipoproteins, maghahatid sila ng triglycerides, gugupitin siya ni lipoprotein lipase. So that's why it's called hormone-sensitive lipase because it's sensitive to the effect of hormones, insulin and glucagon. So let's try to analyze if cyclic AMP is high. Remember, si cyclic AMP, siya yung second messenger ni glucagon. Anong sabi ni glucagon? Fasting tayo. Fasting tayo. Okay, para sa pero anong sabi ni man cyclic AMP? Fasting tayo, fasting tayo, fasting tayo. Diba? So we are in a fasting state. So in the fasting state, gusto ba natin gupitin yung triglycerides? Yes, no? So gusto natin siyang gupitin, no? Bakit natin gustong gupitin yung triglycerides? So if you remember, in the fasting state, you activate hormone-sensitive lipase. So the triglycerides, gugupitin natin yung fatty acids from the glycerol backbone. Why? Yung glycerol, i-convert natin to glucose using gluconeogenesis. What about the fatty acids? Yung fatty acids, i-breakdown natin siya into acetyl-CoA. Bakit kailangan natin gawin yun? Kasi as triglycerides, hindi yan makakapasok ng carb cycle. Masyado yung malaki. As fatty acids, hindi pa din palmitate that has 16 carbons. Kailangan nating i-chop-chop into acetyl-CoA para mapumasok siya ng carb cycle. At the same time, some of the excess acetyl-CoA in the liver will be converted to alternate fuel, your ketone bodies. What about this? Phosphorylation, glycogen synthase. Phosphorylation, glycogen synthase. Is it activated, inhibited, or neither? So, anong tatandaan natin, no? So, yung phosphorylation, anong mnemonic natin? Okay? Walang phosphate, WF. No? Walang phosphate, WF. Well-fed. Fasting, phosphorylated. F. Fasting, phosphorylated. So kapag phosphorylation, phosphorylated fasting state. Okay, glycogen synthase. Okay, so kung glycogen synthase, ano ginagawa ng glycogen synthase? Nagsisynthesize ng glycogen. Glycogenesis. In the fasting state, gagawa ba tayo ng glycogen? No, no. It's inhibited. Why? Kasi baliktad. Kapag fasting state, anong gagawin natin? Glycogenolysis. Dapat magbe-breakdown tayo ng glycogen. Dephosphorylation, pyruvate dehydrogenase. Dephosphorylation, pyruvate dehydrogenase. Is it activated, inhibited, or neither? So, dephosphorylated, walang phosphate, no? Walang phosphate. So, well-fed, WF. So, what does pyruvate dehydrogenase do? Si pyruvate dehydrogenase converts pyruvate to acetyl-CoA. If you remember the crossroads, up, down, left, or right? Down, no? Pyruvate to acetyl-CoA. Ano ba yung up? Pyruvate to lactate. Okay? So, si pyruvate dehydrogenase ang maarte, no? Pinaka-maarte. Kasi ang cofactors niya ay ilan? 5. So, the 5 cofactors are thiamine, FAD, NAD, coenzyme A, and lipoic acid. So, kapag walang phosphate, well-fed, gusto ba natin mag-convert ng pyruvate to acetyl-CoA? Yes, di ba? Why? Kasi marami tayong glucose. Kung maraming glucose, maraming pyruvate, marami tayong kailangan i-convert to acetyl-CoA para maging energy. Okay? Marami. So, ganun lang yun, no? Ganun lang siya kadali. So, remember, when you come across these questions, pag nakakita kayo ng well-fed fasting questions, yun lang tanong mo. Hey, gagawin ko ba ito pag well-fed or kapag fasting? Ano bang mataas na hormone? Insulin, glucagon. The second messenger of insulin is tyrosine kinase. The second messenger of glucagon is cyclic AMP. And then just try to identify anong pathway ba to. And remember our pairs, di ba? So ano yung pairs natin? What's the first pair? Glycolysis and gluconeogenesis. What's the second pair? Glycogenesis and glycogenolysis. And the third pair, fatty acid synthesis or beta oxidation. Yung isa sa kanila, well-fed. Yung isa sa kanila, fasting. Okay? And finally, phosphorylated fasting. Dephosphorylated, walang phosphate, well-fed. Okay? Let's now go to the multiple choice questions. Question number 1. Which of the following statements is incorrect? A. Glutamate is negatively charged at physiologic pH. B. Isoleucine has an aliphatic R group. C. Tyrosine has an aromatic R group. Or D. The pI of arginine is less than 7. Again, which of the following statements is incorrect? A. Glutamate is negatively charged at physiologic pH. B. Isoleucine has an aliphatic R group. C. Tyrosine has an aromatic R group. Or D. The pI of arginine is less than 7. Okay, so first, let's try to analyze. Glutamate is negatively charged at physiologic pH. So glutamate, if you remember, what kind of amino acid? It's acidic. So yung acidic amino acids, ano gusto nilang gawin? They want to donate protons. So if glutamate donates protons, it becomes negatively charged. So that's correct. So remember, si glutamate and aspartate, the acidic amino acids are negatively charged. Letter B, isoleucine has an aliphatic R group. Pag sinabi nating aliphatic, hydrocarbon chain lang siya. Wala siyang rings. So is that correct for isoleucine? Yes, kaya nga diba, siya yung sa branch chain amino acids, valine, isoleucine, and leucine. Letter C, tyrosine has an aromatic R group. Is that correct? Yes, no, meron siyang ring, aromatic ring, yung benzene ring with a high hydroxyl group. So the incorrect answer here is letter D. The pI of alanine is less than 7. Ano ba yung pI? No, remember yung pI, yung isoelectric pH. So this is the pH at which ile-let go niya yung proton niya. If you remember arginine is a basic amino acid. Ano ba yung gustong gawin ng mga basic amino acids? To accept or donate protons? They want to accept. So they have a tendency to hold on to their protons. Kaya ano nangyayari sa pI? Pag basic yung amino acids, no? 'Di ba pataas ng pataas yung pH? Hindi nila basta-basta ile-let go yung proton. Kaya yung pI nila more than 7. Okay, so tatandaan nyo lang, no? Pag acidic amino acid, yung pI nila mababa. Ibig sabihin, mababa pa lang yung pH, ibibigay na nila yung protons kasi gusto nila mag-donate. Yung mga neutral amino acids, nasa gitna, yung pI around 7. Yung mga basic, above 7 kasi hindi nila ile-let go yung proton until mataas yung pH. So that's why you have this table. So if you look at this table, look. Okay, yung mga acidic amino acids, ang pI nila, isoelectric pH mababa. Ibig sabihin, maganto pa lang yung pH, ile-let go na nila, idodonate na nila yung protons. Yung mga neutral, no, at physiologic pH, around 7 yung pI. Yung mga basic, no, matataas yung pI, hinihintay nilang tumaas. Hinihintay nilang tumaas yung pH bago nila ipamigay yung protons nila. Another thing you need to remember, your acidic amino acids are negatively charged at physiologic pH. Yung mga basic amino acids, they are positively charged. Except for histidine, because histidine is a weak base. So, neutral siya at physiologic pH. When you look at the R groups, no, so remember, look here, no, may tinatawag na aliphatic and aromatic. So when you see here, aliphatic, when you look at their R groups, no, puro lang sila carbon, hydrogen, no, carbon and hydrogen. Pag aromatic, no, ito si phenylalanine, tyrosine, and tryptophan, you can see they have the rings. No? They have the rings. Polar uncharged R groups. So at physiologic pH, they will be polar, but they are uncharged because they contain sulfur, oxygen, and nitrogen. Positively charged will be histidine, arginine, and lysine, which are basic. Negatively charged are aspartate and glutamate, which are acidic. Question number 2. Consider the following tetrapeptide. Alanine, glutamyl, glycine, lysine. Which of the following statements is true? A. Edman's reagent will remove glutamate first. B. The C-terminal amino acid is alanine. C. The free alpha amino acid group is found in glycine. Or D. The free alpha carboxyl group is found in lysine. Which of the following is true about alanyl glutamyl glycyl lysine? A. Edman's reagent will remove glutamate first. B. The C-terminal is alanine. C. The free alpha amino group is found in glycine. Or D. The free alpha carboxyl group is found in lysine. So let's try to see. No? So remember, how do we write proteins? How do we write the sequence of amino acids in a protein? We write them from the N-terminal to the C-terminal. No? So N to C. No? So, or A to C, amino to carboxy. So therefore, yung alanine, siya yung nasa N-terminal. No? So mali na yung letter B. Kasi si alanine nasa N-terminal siya dapat. Sinong nasa C-terminal? Si lysine. No? So si lysine, siya yung nasa C-terminal. Si Edman's reagent removes amino acids from the N-terminal. So sinong tatanggalin niyang una? Si alanine, not glutamate. No? Si alanine, not glutamate. Si alanine, siya yung may free alpha amino group kasi kaya nga siya yung N-terminal. Yung amino group niya dito, no, nakalibre. Whereas si lysine, siya naman yung may free carboxyl group dahil siya yung nasa C-terminal, yung COH na libre sa kanya. That's why the correct answer here is letter D. Okay, so tatandaan, no, by convention, N-terminal to C-terminal, the N-terminal will have the free alpha amino group. The C-terminal will contain the alpha carboxyl group. Edman's reagent removes one amino acid at a time, beginning at the N-terminal. Question number 3. Regarding carbon monoxide poisoning, which of the following statements is incorrect? A. In healthy individuals, 1% or less of total hemoglobin is bound to carbon monoxide. B. Carboxyhemoglobin levels in smokers are usually between 3 to 8% and may be higher among chain smokers. C. Dizziness and nausea and confusion begin at carboxyhemoglobin levels more than 30%. Or D. Death normally occurs when carboxyhemoglobin level is more than 60%. Which of the following is incorrect? In healthy individuals, 1% or less of total hemoglobin is bound to carbon monoxide. B. Carboxyhemoglobin levels in smokers are usually between 3% to 8% and may be higher among chain smokers. C. Dizziness, nausea, and confusion begin at carboxyhemoglobin levels more than 30%. Or D. Death normally occurs when carboxyhemoglobin level is more than 60%. So ito, no, tatandaan nyo lang, letter A is true. No? So 1% or less of meron talaga tayong carboxyhemoglobin. No? At 10%, carboxyhemoglobin, very rare yung symptoms. Very rare yung symptoms. Letter B is also correct. No? So usually pag smoker, medyo mataas-taas talaga yung carboxyhemoglobin levels nila. No? So the symptoms begin at 15%. No? The symptoms begin at 15%. So that's why letter C is incorrect, no? So that's why letter C is incorrect because the symptoms, 15% yan magsisimula. At 30 to 50%, mas severe na yung symptoms. Mas severe na yung symptoms. 50%, you have loss of consciousness and coma. 60, really you die, no? That's really when you die. Okay, so tatandaan nyo lang yan, no? So, usually the symptoms will begin at 15%. Although 10 pwede na. 10 pwede na. Number 4, regarding porphyrins, which of the following statements is incorrect? A, it consists of 4 pyrrole rings linked together by methine bridges. B, the porphyrin ring may exist in either chair or both configuration. C, in chlorophyll, porphyrin binds to magnesium instead of iron. D, porphyrinogens are colorless, whereas porphyrins are colored. Regarding porphyrins, which of the following statements is incorrect? A, it consists of 4 pyrrole rings linked together by methine bridges. B, the porphyrin ring may exist in either chair or both configuration. C, in chlorophyll, porphyrin binds to magnesium instead of iron. D, porphyrinogens are colorless, whereas porphyrins are colored. So porphyrin, remember, is not just found in heme or hemoglobin. So yung heme, you also find heme in, aside from hemoglobin and myoglobin, you also find heme in cytochrome C, cytochrome P450s, enzymes such as catalase, tryptophan pyrrolase. No? Now you need to remember, okay, so the porphyrin ring is flat. No? So hindi siya chair at both configurations. So you see here, this is the pyrrole ring, and this is the porphyrin ring. Sa chlorophyll, magnesium is at the center. Whereas in hemoglobin, it's iron. Now, what form of iron? So iron, ferrous, Fe2. No? So Fe2, ferrous. Pag Fe3, ferric yun. No? Fe3 is ferric. So remember, ferru rhymes with 2. Ferric rhymes with 3. No? Ferri, 3. So where do you find ferric? Kailan nagiging ferric yung iron? It's in methemoglobinemia. No? So in methemoglobinemia, ferrous becomes ferric. Question number 5. What is the correct sequence of steps in enzymes in bilirubin metabolism? A, biliverdin reductase, bilirubin UDP glucuronyl transferase, hemoxygenase. B, bilirubin UDP glucuronyl transferase, biliverdin reductase, hemoxygenase. C, hemoxygenase, biliverdin reductase, bilirubin UDP glucuronyl transferase. Or D, hemoxygenase, bilirubin UDP glucuronyl transferase, biliverdin reductase. Again, what is the correct sequence of enzymes? A, biliverdin reductase, bilirubin UDP glucuronyl transferase, hemoxygenase. B, bilirubin UDP glucuronyl transferase, biliverdin reductase, hemoxygenase. C, hemoxygenase, biliverdin reductase, bilirubin UDP glucuronyl transferase. Or D, hemoxygenase, bilirubin UDP glucuronyl transferase, biliverdin reductase. So you just have to remember, no, sa bilirubin metabolism, saan ba siya nagsisimula? So from hemoglobin, magiging heme, no? So hemoglobin magiging heme. So kaya alam mo, mali na yung A and B kasi dapat heme muna. And then heme will be converted to biliverdin, which is, so from purple red, it becomes green. And then biliverdin will be converted to bilirubin. So that's why the correct answer is letter C. No, it's letter C. So you will see here, from heme, it will convert it to, by hemoxygenase, converted to biliverdin. And then biliverdin will be converted to bilirubin, okay, using biliverdin reductase. So what do you need to remember? Bilirubin, this is, ay pag bilirubin lang, unconjugated. No? So lahat ng negative, unconjugated, indirect, no? Unconjugated, indirect, non-polar hemoglobin. So anong ginagawa natin sa bilirubin? We need to attach 2 molecules of glucuronic acid. So dun papasok yung bilirubin glucuronyl transferase. So what is the purpose of attaching glucuronic acid? Now, we need to attach 2 molecules of glucuronic acid to make it more polar. So that's why conjugated bilirubin is polar. direct bilirubin. Okay, conjugated bilirubin is polar. Yun yung sinesecrete natin sa intestines. Okay, so that's the importance of glucuronidation. So kaya hemoxygenase, biliverdin reductase, and then bilirubin glucuronyl transferase. We will give more cases about this later. Question number 6. Which of the following statements describes the classical pathway for complement activation? A. C3p binds to the surface of the pathogen. B. Cleavage of C3 to C3a and C3b. C. IgM and or IgG bind to antigen and form antigen-antibody complexes. D. MBL binds to mannose containing polysaccharides on the surface of bacterial cells. Which of the following statements describes the classical pathway for complement activation? A. C3b binds to the surface of the pathogen. B. Cleavage of C3 to C3a and C3b. C. IgM and or IgG bind to antigen and form antigen-antibody complexes. Or D. MBL binds to mannose containing polysaccharides on the surface of bacterial cells. So ano ba yung purpose ng complement pathway? So yung complement pathway, kaya sinabing complement, it's part of your innate immune system. It complements, no? It complements yung innate immunity natin, usually sa antigen antibodies. So here, the correct answer is this one. No? So IgM and IgG bind to antigen and form antigen-antibody complexes. So remember, no? You will see here, ito yung common pathway. Okay, where C3b is deposited on the microbe. Ang purpose nito, para yung microbe maphagocytose natin or mamatay natin siya. So you will see, what happens is, pag yung C3b nagbind na siya sa microbe, it's either phagocytose more easily, so easily that facilitates phagocytosis, or the membrane attack complex will lyse the microbe. So meron tayong 3 ways to activate it. The classical pathway is where the antibody binds to the antigen or the microbe. And then you have the lectin pathway. You have a mannose that binds to the lectin. And then you have the alternate pathway. Okay? So tataka kayo, bakit ganun? No? So sometimes there are a lot of immunology questions in biochemistry. So ang mga related topics na tinatanong sa biochem will be immunology, hemostasis, coagulation cascade. So aaralin niyo yan, ha? Please. We did not discuss this in detail in biochemistry because these are already discussed in physiology and sometimes even in pathology. But you need to remember that this can be asked, no? So, aralin niyo to, ha? So, complement pathway, inflammation, hemostasis, coagulation, no? Kasama yan. Question number 7. Regarding immunoglobulins, which of the following is incorrect? A. IgM has the highest molecular weight. B. IgA can exist either as a monomer or a dimer. C. IgG is most abundant in serum. Or D. IgE can cross the placenta. Regarding immunoglobulins, which of the following is incorrect? A. IgM has the highest molecular weight. B. IgA can exist either as a monomer or a dimer. C. IgG is the most abundant in serum. D. IgE can cross the placenta. So it's letter A. IgM has the highest molecular weight. That's true, no? Because IgM actually exists as a pentamer. No, IgM exists as a pentamer, 5 immunoglobulins. Letter B. IgA can be monomer or dimer. That's also true. Letter C. IgG is the most abundant. That's also correct. No, IgG yung most common. Letter D is wrong. IgE can cross the placenta because the only one that can cross the placenta will be your IgG. So if you look at this table, again, as I've said, please study your immunoglobulins. No, immunology, may mga immunology questions in biochemistry. So when you look, percent of total immunoglobulins, pinakamadami si IgG, most abundant. But always remember, the first to rise during a first infection, first exposure, sino unang tataas? It's actually IgM. IgM. And then, long-term immunity is conferred by IgG. Structure, okay? IgA is a monomer or a dimer. IgM is a pentamer. No? So pwede siyang monomer or pentamer, 5 IgGs grouped together. IgM is the largest. No? IgM is the largest. Okay, so placenta, transplacental passage, you can see here, no? Transplacental passage, IgG lang. Complement system, IgM and IgG. Remember the classical pathway. Major functions of your immunoglobulins, no? So again, you also need to review this, no? You also need to review this during the main antibody in the primary response will be IgM, no? Secondary response, IgG, no? Found in found in mucous membranes, no? IgA. Parasitic infections. So parasitic infections or allergic reactions, no? Hypersensitivity reactions, IgE. IgD, hindi nila alam, no? IgD hindi talaga nila alam. They say it works kasama yan nung B cells, no? But it's not really clear what its role is. So pag tinanong kayo, so this is an easy question. Which immunoglobulin is most important for mucosa-associated lymphoid tissue? So madali na to, IgA. No? So sa respiratory sa lining, so sa lining of the respiratory system, genitourinary system, gastrointestinal system, IgA is very important. Question number 9. Which of the following is the major protein in human plasma responsible for about 75% of the oncotic pressure in blood? A. Albumin, B. Alpha-1 globulin, C. Beta globulin, or D. Gamma globulin. Which of the following is the major protein in human plasma responsible for about 75% of the oncotic pressure in blood? A. Albumin, B. Alpha-1 globulin, C. Beta globulin, or D. Gamma globulin. So remember, your blood contains ano ba yung total protein, ano ba yung majority of proteins in the body? It's either albumin or globulin. No? Albumin or globulin. Which one's more important? Mas important yung globulin. Ano? Kaya nga yung albumin, kapag malnutrition, yan yung unang bumababa. Remember, you spared the more important ones first. The correct answer here is albumin. No? So albumin, siya yung pinakamadami. No? Okay, so ang isa natin ginagamit yung albumin, di ba, for protein transport. You will see here, no? So normal protein, yung spectrometry natin. So albumin yung pinakamadami. No? Albumin yung pinakamadami, and this shows you the other proteins in the body. This shows you the other proteins in the body. Number 10, which group of patients are at risk of developing Alzheimer's disease at age 40 years or younger? A. Down syndrome, B. Klinefelter syndrome, C. Marfan syndrome, D. Zellweger syndrome. Which of the following groups of patients are at risk of developing Alzheimer's disease at age 40 years or younger? A. Down syndrome, B. Klinefelter syndrome, C. Marfan syndrome, or D. Zellweger syndrome. The correct answer here is Down syndrome. There was a time when they asked so many questions about Alzheimer's disease. Again, that may just be once or twice. No, these things really are nice to know. Number 11, which of the following statements is incorrect regarding Alzheimer's disease? A. Brain biopsy typically shows evidence of cholinergic excess. B. Extracellular plaques consist mainly of amyloid beta protein. C. Individuals homozygous for ApoE4 have a 16-fold higher risk of developing Alzheimer's disease. Or D. Neuronal tangles consist of microtubule-associated protein tau, which is normally soluble. Which of the following statements is incorrect regarding Alzheimer's disease? A. Brain biopsy typically shows evidence of cholinergic excess. B. Extracellular plaques consist mainly of amyloid beta protein. C. Individuals homozygous for ApoE4 have a 16-fold higher risk of developing Alzheimer's disease. Or D. Neuronal tangles consist of microtubule-associated protein tau, which is normally soluble. The correct answer here is letter A. No? So, ang nangyayari sa Alzheimer, what happens is, yung cholinergic pathways nababawasan. No? Yung pathways for acetylcholine. No? Hindi siya sobra. Actually, nababawasan. What happens in Alzheimer's? So if you remember, this is the amyloid precursor protein. So yung amyloid precursor protein normally, using alpha secretase, no, and gamma secretase, you end up with soluble peptides. So what happens here is that yung amyloid precursor protein, okay, pag na-cleave siya, no, nagkakaroon tayo ng A-beta protein. No, so instead of being cleaved by alpha secretase, what happens is this, no? So you have an A-beta protein, and that leads to formation of plaques and neurofibrillary tangles. Plaques and neurofibrillary tangles. And you see here, this is a normal individual. So sa Alzheimer, nababawasan ito yung cholinergic pathways. These are yung red, yun yung dotted lines, yun yung nawawala sa kanya. Question number 12, regarding collagen, which of the following statements is incorrect? A. Synthesis of pro-collagen from precursors of polypeptide chains is an extracellular process. B. Pro-collagen is converted to collagen by cleaving amino acids from the N-terminus. C. It exists mainly in non-fibrous form in the basement membrane of kidney glomeruli and lens capsule. D. Hydroxyproline and hydroxylysine are commonly found in the X position. Regarding collagen, which of the following statements is correct? A. Synthesis of pro-collagen from precursor polypeptide chains is an extracellular process. B. Pro-collagen is converted to collagen by cleaving amino acids from the N-terminus. C. It exists mainly in non-fibrous form in the basement membrane of kidney glomeruli and lens capsule. D. Hydroxyproline and hydroxylysine are commonly found in the X position. The correct answer here is letter C. No? So, bakit mali yung letter A? So, you see, when you synthesize collagen, no? So, intracellular yon. No? The synthesis of pro-collagen, so from in the nucleus, yun, then go translation, no? And then, so you'll see here, you translation, you synthesize the proteins, that becomes your pre-pro-collagen, and then you will see it's hydroxylated. So, glycine XY. Yung hydroxyproline and hydroxylysine, doon sila sa Y, hindi doon sa X. No? So, hydroxylation, you see, you add hydroxyl group, and then you now have your pro-collagen. Yung pro-collagen, exocytosis. So, yung cleavage, yung pagtanggal ng N tsaka C terminal, sa doon ay extracellular process. Kaya, mali yung letter B. No? Mali yung letter B because N-terminal and C-terminal dapat. Mali yung letter A kasi pro-collagen should be an intracellular process. Mali yung letter D kasi hydroxyproline and hydroxylysine dapat dun sa position Y. Okay, so be familiar with this. No? So collagen synthesis. Remember, collagen is a triple helix. Even the triple helix formation happens inside the cell. So ito lang naman yung tinatanong nila dyan, ano yung intracellular tapos ano yung intracellular tsaka ano yung extracellular pathway. Question number 13. Which of the following is a sugar alcohol used as an artificial sweetener? A. Erythritol. B. Galactitol. C. Glucuronic acid. D. Mannitol. Which of the following is a sugar alcohol used as an artificial sweetener? A. Erythritol. B. Galactitol. C. Glucuronic acid. D. Mannitol. So you need to know the sugars, no, the carbohydrates. The correct answer here is erythritol. Ano ba yung erythritol, galactitol, and mannitol? What are they? They are your sugar alcohols. No, what do you need to remember about your sugar alcohols? Your sugar alcohols attract water. No, remember they attract water. That's why mannitol is used for raise intracranial pressure. No, we use it to lower intracranial pressure by decreasing cerebral edema. And how does it do that? It attracts water. It promotes the promoting diuresis. Galactitol, mababanggit natin yan later sa symptoms of abnormal galactose metabolism. What about glucuronic acid? No? So kung yung sugar alcohols are produced by reduction, glucuronic acid is produced by oxidation of glucose. So if you oxidize glucose, you get glucuronic acid. If you reduce glucose, what do you get? You get sorbitol. No, you get sorbitol. So para saan yung glucuronic acid? Glucuronic acid, if you remember, it's produced in the uronic acid pathway. Saan natin ginagamit sa glucuronic acid? Binanggit natin kanina. Ginagamit natin siya for bile, not for bilirubin, no? Glucuronidation of bilirubin, no? The bilirubin triglucuronide to convert it from indirect to direct bilirubin, non-polar to polar bilirubin. What else? No, yung glucuronidation, ginagamit din natin yun sa metabolism of drugs, no? So if you want to make drugs more polar, more readily excretable, they undergo glucuronidation. Where else do you find glucuronic acid? Sa glycosaminoglycans. So remember, glycosaminoglycans usually alternating acidic sugar and amino sugar. So sila yung acidic sugars. Question number 14. Regarding mineral metabolism, which of the following statements is incorrect? A. Acrodermatitis enteropathica is treated with oral zinc supplementation. B. Aside from hypocalcemia, hypomagnesemia can also result in tetany. C. Deficiency in molybdenum leads to accumulation of sulfite because it is a cofactor of sulfite oxidase. D. Selenium protects against oxidative injury in tissues. E. Synthesis of melanin, catecholamines, and collagen require iron. Regarding mineral metabolism, which of the following statements is incorrect? A. Acrodermatitis enteropathica is treated with oral zinc supplementation. B. Aside from hypocalcemia, hypomagnesemia can also result in tetany. C. Deficiency in molybdenum leads to accumulation of sulfite because it is a cofactor of sulfite oxidase. D. Selenium protects against oxidative injury in tissues. E. Synthesis of melanin, catecholamines, and collagen require iron. So the correct answer here, the one that's incorrect is letter E. So it's not iron but copper. So all the rest are correct. No? All the rest are correct. So tatandaan nyo to ha, kasi yun nga yung mga minerals from time to time tinatanong sila ha. So ito zinc, no, acrodermatitis enteropathica yun, no? So kulang sa zinc. Yung letter B naman, no, calcium and magnesium, para sila nagkukos ng tetany. Molybdenum, yung selenium ito, no, saan yun narinig yung selenium? If you review your glutathione, no, so glutathione peroxidase kasama siya doon. Okay? So question number 15. Which pathway yields glucose? Glycolysis, gluconeogenesis, glycogenolysis, glycogenesis. Which pathway yields glucose? Glycolysis, gluconeogenesis, glycogenolysis, glycogenesis. So sometimes no, mahilig din sila sa ganitong mga questions. No? So 1 and 2, 1 and 3, 2 only, 2 and 4, 2 and 4. Just ang first step talaga sa questions na to, no, try to eliminate choices. So ito dapat madali na to, no? So remember, ito lang yung 4 Gs natin, no? 4 Gs. So among the 4, no, sino ba yung magpo-produce ng glucose? Hey, glycolysis, will it produce glucose? No, it will break down glucose. Gluconeogenesis, yes. Glycogenolysis, yes. And then glycogenesis, wrong, because glycogenesis will synthesize glycogen, not glucose. So the correct answer here is 2 and 3. 2 and 3. Next, question number 16. Which pathways generates NADH? Glycolysis, gluconeogenesis, Krebs cycle. Which pathways generates NADH? Glycolysis, gluconeogenesis, Krebs cycle. So glycolysis, does it produce NADH? Yes, no? So remember, may NADH doon. We will either use that to convert pyruvate to lactate or dadahil natin sa electron transport chain using the glycerophosphate or malate aspartate shuttle. Gluconeogenesis. Does it produce NADH? No. In fact, it uses NADH. No, gagamit yan ng NADH. How about Krebs cycle? Yes. So you generate how many? You generate 3 molecules of NADH in the Krebs cycle. That's why the correct answer here is 1 and 3. Which pathway is active during the post-absorptive state? Beta oxidation, lipogenesis, ketogenesis. Which pathways are active during the post-absorptive state? Beta oxidation, lipogenesis, or ketogenesis. So, kapag fasting tayo, mag-breakdown ba tayo ng fat? Beta oxidation? Yes. Gagawa ba tayo ng fat? Lipogenesis? No. Gagawa ba tayo ng ketogenesis? Yes. So, the correct answer here is 1 and 3. No, so, beta oxidation and ketogenesis. Paano kapag ketolysis? Nagkiketolysis din ba tayo pag fasting? Yes. So, tatandaan nyo, ketogenesis and ketolysis, kahit na opposite pathways sila, they both happen during the fasting state. Yun yung exception. No? So, yun yung exception. No? Yung tatlong pairs, isa sa fasting, isa sa well-fed. Pero yung ketogenesis and ketolysis, they're opposite but they both occur during fasting. Question number 18. Which pathways generates ATP? Glycolysis, hexose monophosphate shunt, beta oxidation. Glycolysis, hexose monophosphate shunt, or beta oxidation. So sa glycolysis, may ATP ba? Yes, you have 2 steps that generate ATP, no, via substrate level phosphorylation. Kaya nga you produce 4 ATPs in glycolysis. B, hexose monophosphate shunt. Gagawa ba tayo ng ATP doon? No. So remember, the pentose phosphate pathway, you don't use up ATP. Wala siyang kinalaman sa ATP. Beta oxidation, do you generate ATP? Yes. No. So marami tayong nakukuhang ATP sa beta oxidation. So the correct answer is 1 and 3. Which pathway involves oxidation reactions? A, lipolysis, beta oxidation. 2, Krebs cycle. B, hexose monophosphate shunt. So, yung lipolysis, nasabi ko na, no, beta oxidation yung other term niya. So, di ba, kaya nga siya OHOT, oxidation, hydration, oxidation, thiolysis. So, tama yun. No? So, generally, yung mga oxidation reactions for digestion kasi yan. Krebs cycle, meron bang oxidation sa Krebs cycle? Yes, kaya nga may mga dehydrogenases, di ba? So, yung mga dehydrogenases, they are oxidation reactions, no? So, may ma-oxidize, may ma-reduce. How about the hexose monophosphate shunt? May dehydrogenase ba na enzyme sa hexose monophosphate shunt? Meron, yung G6PD, di ba? Glucose-6-phosphate dehydrogenase. That's another oxidation reaction. So, kaya all of them, 1, 2, and 3. Question number 20. Within the absence of beta oxidation, which pathway will be impaired? In the absence of beta oxidation, which pathway will be impaired? Glycolysis, gluconeogenesis, or glycogenolysis? Glycolysis, gluconeogenesis, or glycogenolysis? So here now we always emphasize this, no? Okay, the correct answer here is gluconeogenesis. So remember, to create glucose, you need to burn fat. Beta oxidation provides the energy needed for gluconeogenesis. So ito nga yung principle behind weight loss in a ketogenic diet. So sa ketogenic diet, no? Kaya tayo nag-lose ng weight kasi hindi tayo kumakain ng carbohydrates. And when we don't eat carbohydrates, we are forced to create glucose. And to create glucose, you need to burn fat. Okay? So yung beta oxidation, kaya yung mga enzyme deficiencies in beta oxidation, kunyari yung carnitine palmitoyl transferase deficiency, pag wala nun, what will happen? You will become hypoglycemic. Okay? So that's the end of the first part. Take a quick break and let's resume with part 2. Let's resume our biochemistry cases. So now we'll go to the cases proper. No? So we'll go to the cases proper. Okay, let me just sort this out. Okay. So how do we approach cases? So when answering cases sa board exam, here's my suggestion. Underline, so ang most important thing you need to remember, look at the question first. I know this is counterintuitive, no? But you waste a lot of time kasi minsan lalo na pag mahaba yung case, no? Yung pala napakasimple lang ng tanong, napakasimple lang ng tanong. To be smart about these things, so always look at the question first, no? Kung ano yung pinakadulo, no? Para alam mo na kung ano yung hahanapin mong information. And then underline the relevant parts of the case, underline the relevant parts of the case, and then try to decide what pathway is involved. So let's put it to a test. Let's try to see. Here. Question number 1. A 35-year-old farmer was brought to the emergency room because of profuse sweating, blurring of vision, salivation, and vomiting. He was bradycardic and diaphoretic. His family said he was applying an insecticide just before he experienced these symptoms. Which type of inhibition does this poisoning represent? A, competitive, B, non-competitive, C, reversible, D, uncompetitive. A 35-year-old farmer was brought to the emergency room because of profuse sweating, blurring of vision, salivation, and vomiting. He was bradycardic and diaphoretic. His family said he was applying an insecticide just before he experienced these symptoms. Which type of inhibition does this poisoning represent? Right? A, competitive, B, non-competitive, C, reversible, or D, uncompetitive. O, tingnan natin yung scenario. No? So yung scenario dito, what's being described here? So this is organophosphate poisoning. So organophosphate poisoning. Pag sinabi natin organophosphate poisoning, what happens? Your insecticide binds to the what enzyme? Acetylcholinesterase. Acetylcholinesterase is supposed to break down acetylcholine into acetyl-CoA and choline. When organophosphate binds to acetylcholinesterase, hindi na siya makapag-function, leading to accumulation of acetylcholine in the synapse. So kaya cholinergic effects to, no? So these are the cholinergic effects. So mnemonic dumbbells. So what kind of inhibition is that? So the correct answer here is non-competitive. No, it's a non-competitive inhibitor. So if you remember our diagram, this is the acetylcholinesterase enzyme. Magbabind sa kanya si organophosphate, no? The substrate, no? So the enzyme becomes defective. The enzyme becomes effective. In contrast, pag competitive inhibition, no? Pag competitive inhibition, the inhibitor looks like the substrate. So the substrate cannot bind to the active site. Okay? The substrate cannot bind to the active site. Now, anong important, no? Remember, the thing about this is to remember the effects on enzyme kinetics. Kapag competitive inhibitor, what happens? If you have a competitive inhibitor, Km, no? Your Km increases, the affinity goes down. Km goes up, affinity goes down. Vmax remains the same. Your Vmax remains the same. Kapag non-competitive inhibitor, the Vmax goes down. Km and affinity remain the same. No, Km and affinity remain the same. How do you overcome a competitive inhibitor? Pag competitive inhibitor, you just increase the substrate. Kapag non-competitive inhibitor, you increase the enzyme. So ito pa, yung graph na ito yung very important. No? So when you look at the graph, yung nasa left, the left graph illustrates, let's try to analyze. So yung x-axis represents 1 over substrate, y-axis 1 over velocity. No? So it's a double reciprocal. So you will see, so yung may inhibitor, saan sila pareho? Sa velocity, di ba? Doon sa y-axis. Dito naman, saan sila pareho? Sa km, doon sila pareho. So therefore here, ang pareho dito ay Vmax. So saan pareho yung Vmax? Sa competitive inhibition. So you will see Km is higher with the inhibitor, but Vmax remains the same. That's why they intersect at the y-axis. In contrast here, Km is the same. That's why they intersect at the x-axis. No, they intersect at the x-axis. Vmax is lower. So this is a reciprocal plot kaya mas mataas yung representation sa kanya. Okay, so remember competitive inhibitors, y-axis sila nag-intersect. Non-competitive inhibitors sa x-axis. What's the definition of Km? How much substrate is needed so that the velocity of the enzyme is half its maximum. And Km is inversely related to affinity. As Km goes up, affinity goes down. As Km goes down, affinity goes up. Question number 2. A 54-year-old firefighter was brought to the emergency room from the scene of a fire because of headache, dizziness, and confusion. He had pink-red discoloration of his skin and mucous membranes. Which of the following explains his signs and symptoms? A. Cytochrome oxidase is inhibited. B. Electron transport and phosphorylation are uncoupled. C. NADH dehydrogenase is inhibited. Or D. There is inadequate supply of ADP. A 54-year-old firefighter was brought to the emergency room from the scene of a fire because of headache, dizziness, and confusion. He had pink-red discoloration of his skin and mucous membranes. Which of the following explains his signs and symptoms? A. Cytochrome oxidase is inhibited. B. Electron transport and phosphorylation are uncoupled. C. NADH dehydrogenase is inhibited. Or D. There is inadequate supply of ADP. So let's analyze. Ano ba yung mga buzzwords dito, no? So pag yung pink-red discoloration, very characteristic yan, no? Pink-red discoloration. Tapos fire, no? So fire, may smoke, no? What is this? This is carbon monoxide poisoning. So yung pink-red discoloration, carbon monoxide poisoning, very classic. Most of the time, it's a post-mortem finding, yung pink-red discoloration na yun, no? So now, when you look at the choices, no, ano ba yung mga choices na yan? These are the choices on what are those conditions that decrease ATP production. Anong kinalaman doon ng carbon monoxide? If you remember, carbon monoxide inhibits which one? Carbon monoxide inhibits complex number 4. That's why the correct answer here is letter A, no? Because it inhibits cytochrome oxidase, which is complex 4. Okay? So inhibition of complex 4. So remember, no? What are the ways, no? What are the ways by which we can decrease in ATP? We can decrease one of the complexes, no? Complex 1 to 4. So titingnan natin yung table ulit later. Number 2, we can uncouple electron transfer chain oxidative phosphorylation, yung mga uncouplers. Diba? Or pwedeng i-affect natin yung, or i-directly inhibit natin si complex 5, direct inhibition of complex 5. Or we can affect the transport of ADP and ATP, such as in atractyloside, no? Such as in atractyloside. Yung direct inhibition ng complex 5, sinong gumagawa nun? Si oligomycin, no? Oligomycin. So again, just a review, no? Remember the electron transport chain, ETC, in the inner mitochondrial membrane, complex 1 here, complex 2 here, complex 4 is here. Very important, no? Complex 3 and complex 4, pag binlock natin sila, hindi na makakarating yung electrons kay oxygen. So that's why they are poisons. Ayaw mo yun. If you block just complex 1, pwede pa dumaan kay complex 2. If you block kay complex 2, pwede pa dumaan kay complex 1. And then, what else? Pag nagpasa-pasa ng electrons, these are redox reactions. You generate protons in the intermembranous space. The intermembranous space becomes more positive, becomes more acidic. They don't want it there. They want to go back. They pass to complex 5. Pag lusot sa complex 5, ting! You just produced ATP. And you now have ATP here. This is the table I was referring to, no? So if you remember, so memorize nyo to, ha? Even the names. So complex 4 is cytochrome C oxidase. Nandun yung carbon monoxide. Okay, nandun yung carbon monoxide. Other complex 4 inhibitors, cyanide. Cyanide poisoning. and hydrogen sulfide. Complex 1, pinakasikat, barbiturates, amytal. Complex 2, malonate. Complex 3, antimycin A and dimercaprol. So dimercaprol is a chelating agent. So kabisaduhin niyo lang ha. Kabisaduhin niyo lang yan. Very important. Question number 3. A 34-year-old female undergoing general anesthesia for the first time suddenly developed high fever, muscle rigidity, and tachycardia. Which of the following explains her signs and symptoms? A. Cytochrome oxidase is inhibited. B. Electron transport and phosphorylation are uncoupled. C. NADH dehydrogenase is inhibited. D. There's inadequate supply of ADP. A 34-year-old female undergoing general anesthesia for the first time suddenly developed high fever, muscle rigidity, and tachycardia. Which of the following explains her signs and symptoms? So same choices as earlier. Ano kayang case to? So anesthesia, high fever, muscle rigidity, tachycardia. This is malignant hyperthermia. No? So this is malignant hyperthermia. Anong kinalaman nun sa ATP? It means she is not producing ATP. Instead of producing ATP, she is generating heat. No? So saan, alin ba dyan yung mga inhibitors? Alin ba dyan yung mag-generate ng heat instead of ATP? It will be your uncouplers. So that's why the correct answer is letter B. So in here, no, what happens? So remember, yung mga protons, hindi sila makabalik. Gusto nila dapat bumalik through complex 5. Kaya ang nangyayari, kasi yung kaya napipilitan silang dumaan kay complex 5 because the inner membrane is impermeable. No? Is impermeable. Ang gagawin ng uncouplers, gagawin nilang permeable. Kapag permeable na, hindi nila dumaan, kailangan dumaan kay complex 5. No? They don't have to pass through complex 5. So instead of passing, dito na sila dadaan. So wala tayong ATP. Walang ting. Walang ting. Okay? So ngayon, kung walang ting, walang ATP. Instead, you generate heat. Okay? Question number 4. A 47-year-old alcoholic is admitted in the hospital because of confusion, nystagmus, and difficulty walking. Which of the following enzymes is expected to be impaired in this patient? A 47-year-old alcoholic is admitted in the hospital because of confusion, nystagmus, and difficulty walking. Which of the following enzymes is expected to be impaired in this patient? A. Alpha-ketoglutarate dehydrogenase. B. Isocitrate dehydrogenase. C. Malate dehydrogenase. Or D. Succinate dehydrogenase. A. Alpha-ketoglutarate dehydrogenase. B. Isocitrate dehydrogenase. C. Malate dehydrogenase. Or D. Succinate dehydrogenase. So when you look at the case, no? Alcoholic, buzzword na agad yan. Alcoholic, confusion, nystagmus, difficulty walking, these are signs and symptoms of Wernicke-Korsakoff, no? Wernicke-Korsakoff syndrome. So let's try to see, ano ba yung deficiency sa Wernicke-Korsakoff? Vitamin B1. So thiamine deficiency. So ang tanong dito, sino ba yung enzyme dyan na kailangan ng thiamine? Which one requires thiamine? These are enzymes of what pathway? These are enzymes of the Krebs cycle. And the one that requires thiamine is alpha-ketoglutarate dehydrogenase. Remember, si alpha-ketoglutarate dehydrogenase, kasing arte siya ni pyruvate dehydrogenase. No? So si pyruvate dehydrogenase, magpinsan sila. At kaya kailangan din niya ng thiamine. No? Kasi kasama, kailangan din niya ng 5 cofactors that we enumerated. So remember, no? So remember your Krebs cycle, no? How many carbon dioxide do you produce? 2. Bakit 2? Kasi 2 carbon si acetyl-CoA. 2 carbon papasok, 2 carbon din yung lalabas. How many NADH? 3. Yung mga dehydrogenases. Only the first 2 will produce carbon dioxide. Yung pangatlo, wala na. Kasi nga, 2 lang carbon yung pumasok, 2 lang yung lalabas. FADH, saan siya lalabas? Dito, kasabay ni fumarate. No? So remember, yung 2 F, sabay lalabas. And finally, ang lumalabas sa susu ay gatas. You produce 1 GTP. Other important question, acetyl-CoA, what is the source of acetyl-CoA when you're well-fed? What pathway? Glycolysis. What about in the fasting state? What's the source of acetyl-CoA? Beta oxidation. Okay. Question number 5. A 32-year-old alcoholic, again alcoholic na naman, was admitted to a substance abuse center. He was given a drug to try to discourage him from drinking alcohol. Which of the following would become elevated and lead to nausea and vomiting if he continues to drink alcohol? A. Acetaldehyde, B. Acetic acid, C. Methanol, or D. Methanol. A 32-year-old alcoholic was was admitted to a substance abuse center. He was given a drug to try to discourage him from drinking alcohol. Which of the following would become elevated and lead to nausea and vomiting if he continues to drink alcohol? A. Acetaldehyde, B. Acetic acid, C. Ethanol, or D. Methanol. So, anong drug kaya yon? Yung muna yung question. So, alcohol, be very familiar with alcohol metabolism. Read about alcohol, ha? So, you might need to do additional readings on alcohol. Ito yung isa sa mga favorite nila, no? So, correct answer here is acetaldehyde. So, if you remember, ethanol is converted to acetaldehyde and then to acetate. And the one that causes the symptoms of hangover is acetaldehyde, no? So yung acetaldehyde, yan yung reason, no, kung bakit madali tayong bakit ka namumula, bakit ka nahihilo. So yung mga madaling mamula, madaling mahilo, kulang sila ng aldehyde dehydrogenase. So aldehyde dehydrogenase deficiency. So sa mga Asians, no? So ngayon, si aldehyde dehydrogenase, ini-inhibit siya ni disulfiram. That was a drug given to the patient. So yung disulfiram, no? Yun yung drug na binigay. So pag binigyan natin ng disulfiram, mabablock si aldehyde dehydrogenase, madaling mag-accumulate si acetaldehyde. Now, the other thing you need to remember here in this diagram, very important, ito lang, kung may tatandaan lang kayong kaisa-isa sa diagram na to. Whenever you metabolize excessive amounts of alcohol, what increases? NADH. So yung mga metabolic effects ng alcoholism, no? It's because of excessive NADH. So let's look at the next question. Number 6. After breaking up with his girlfriend of 10 years, a 26-year-old male drank an unspecified number of bottles of beer. A few hours later, he was brought to the emergency room unresponsive. Which of the following is least likely to be observed? A. Hypoglycemia. B. Lactic acidosis. C. Increased acetoacetate. D. Increased NAD-NADH ratio. After breaking up with his girlfriend of 10 years, a 26-year-old male drank an unspecified number of bottles of beer. A few hours later, he was brought to the emergency room unresponsive. Which of the following is least likely to be observed? A. Hypoglycemia. B. Lactic acidosis. C. Increased acetoacetate. D. Increased NAD-NADH ratio. So the correct answer here is letter D. No? So remember, sabi natin, no? When you metabolize excessive amounts of alcohol, dapat anong mangyayari? Anong tataas? Tataas dapat yung NADH, no? So dapat anong mangyayari sa NAD-NADH ratio? Dapat bababa. So patunayan natin na tama itong tatlo. Itong 3, very important, no? Hypoglycemia, lactic acidosis, and what is acetoacetate? Acetoacetate is a ketone body, no? So ketosis, no? So hypoglycemia, lactic acidosis, ketoacidosis. So bakit nagkakaganon? Sabi natin, no? Taas ang alcohol, taas ang NADH relative to NAD, no? So bababa yung NAD-NADH ratio. So pag maraming NADH, again, pyruvate is converted to lactate. That's why you have lactic acidosis. No? That's why you have lactic acidosis. Oxaloacetate is brought back to malate. So ngayon, ano bang role ni oxaloacetate? Si oxaloacetate siya dapat yung sasalubong kay acetyl-CoA. Diba? Sa Krebs cycle. So kung wala nang sasalubong kay acetyl-CoA, saan pupunta si acetyl-CoA? Sa ketogenesis. That's why you have increased acetoacetate ketoacidosis. And then finally, kung babagsak si pyruvate, babagsak si oxaloacetate, di ba? Kasi bumabalik sila doon. You don't have pyruvate to oxaloacetate. Pyruvate to oxaloacetate is the first step of gluconeogenesis. So you will not be able to undergo gluconeogenesis, resulting in hypoglycemia. So remember those three: hypoglycemia, lactic acidosis, ketoacidosis, acute effects of alcohol intoxication. Question number 7. A 12-year-old boy was brought to an ophthalmologist by his mother because of blurring of vision that started 2 months ago. He initially noticed that the vision in his left eye was blurry, followed by his right eye several weeks later. On examination, he has nystagmus and papilledema. The most likely diagnosis follows which pattern of inheritance? A. Autosomal dominant, B. Autosomal recessive, C. X-linked recessive, or D. Mitochondrial. A 12-year-old boy was brought to an ophthalmologist by his mother because of blurring of vision that started 2 months ago. He initially noticed that the vision in the left eye was blurry, followed by his right eye several weeks later. On examination, he has nystagmus and papilledema. The most likely diagnosis follows which pattern of inheritance? A. Autosomal dominant, B. Autosomal recessive, C. X-linked recessive, or D. Mitochondrial. So yung blurring of vision, no, ano lang iisipin natin pag biochemistry. So ito, no, metabolic, genetics yung questions. No? So ito, this is probably a mitochondrial disease. Which mitochondrial disease? Okay, this is Leber hereditary optic neuropathy. No? So ito yung typical, no, for Leber hereditary optic neuropathy. Blurring of vision in one eye followed by the other eye weeks to months later. The important thing to remember will be the pattern of inheritance. No? So sa pag mitochondrial disorder, if the mother is affected, all the children are affected. If the father is affected, no one is affected because majority of your mitochondrial DNA will only come from your mother. So actually, it's already been demonstrated. Parang I think I came across a news article before that very, very, very rarely you can also get mitochondria from your father. Question number 8. A 35-year-old female was brought to the emergency department because of sudden onset right-sided weakness with vision loss. She has had previous acute attacks before in which the neurologic symptoms would resolve in 24 to 48 hours. Since she started having these episodes in the last 5 years, she has had behavioral changes and memory problems. On examination, she has expressive aphasia, right hemiplegia, and right homonymous hemianopia. Serum lactate was elevated, and MRI confirmed an acute infarct. Her mother, uncle, and 2 other siblings also exhibit the same symptoms, but the children of her maternal uncle do not. What is the most likely diagnosis? Homocystinuria, Leber hereditary optic neuropathy, MELAS, or methylmalonic aciduria. So itong mga choices, no, itong mga choices na to, yung mga stroke in the young, no, except for Leber hereditary optic neuropathy. So yung homocystinuria, MELAS, saka methylmalonic aciduria, lahat yan nagmamanifest with stroke in the young. Pero ano kaya ito? So you will see, no, stroke siya, no, kasi tinan mo, sudden onset right-sided weakness with blurring of vision, tas paulit-ulit, no, paulit-ulit. So you will see meron siyang neurologic deficits. Tas na-confirm sa imaging na meron siyang infarct. Yun yung mga keywords. Ano dito ngayon yung nagsasabi sa atin, ito talaga to, no? It's the pattern of inheritance. So you will see yung mother, tsaka yung mga kapatid niya, di ba? Merong symptoms, no? Pero yung anak ng tito niya, walang sakit, no? Yung anak ng tito niya, ibig sabihin, yung tito niya malamang meron, pero yung mga anak nun walang sakit. So this is mitochondrial. And the only one that's mitochondrial here will be MELAS. Mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. Okay, so mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. So later, no, yung homocystinuria, stroke in the young din yan. Pero anong key finding dyan? No? Sa homocystinuria, dapat nagbanggit siya ng lens displacement. No, may lens displacement yung homocystinuria. Tapos, wala yung elevation of metabolites. No? So, like methionine. No? Hindi nagsabi na mataas yung methionine, mababa yung cysteine. Yung methylmalonic aciduria naman, no? methylmalonic acid, no? So, tataas yung methylmalonate. So, hindi nagbanggit nun. Tsaka talaga ito, yung clue dito, yung mitochondrial pattern. Question number 9. A 6-year-old girl was brought to a pulmonologist because of recurrent respiratory tract infection. She was recently hospitalized because of severe bilateral pneumonia after presenting with wheezing, cough, and fever. Since she was an infant, she has had steatorrhea and malabsorption. She has also had a history of intestinal obstruction as a neonate. She is noticeably short and small for her age. Her parents are not consanguineous and her older brother is healthy. What is the most likely diagnosis? Chronic granulomatous disease, cystic fibrosis, severe combined immunodeficiency, or X-linked agammaglobulinemia. A 6-year-old girl was brought to a pulmonologist because of recurrent respiratory tract infection. She was recently hospitalized because of severe bilateral pneumonia after presenting with wheezing, cough, and fever. Since she was an infant, she has had steatorrhea and malabsorption. She has also had a history of intestinal obstruction as a neonate. She is noticeably short and small for her age. Her parents are not consanguineous, and her older brother is healthy. What is the most likely diagnosis? So this is cystic fibrosis. So ano yung clues na cystic fibrosis to, no? So you will see, no, yung mga mucosal surfaces, no? So kaya siya may recurrent respiratory tract infection, tapos may intestinal obstruction din siya, no? Okay? So you see, ito yung spectrum, no? So sa cystic fibrosis, remember, it's most commonly caused by a frame shift mutation in the CFTR gene, no? Frame shift mutation in the CFTR gene. So the role is that the CFTR protein regulates, it's an ion channel. It regulates the volume, liquid volume, and epithelial surfaces by chloride secretion and inhibition of sodium absorption. Kaya nga, ang test dito, no, chloride sweat test. No? So they measure sweat chloride. So usually, no? So you measure sweat electrolytes levels, no? So you measure sweat electrolytes levels. So usually sodium and chloride levels yung mini-measure dito. So if it's elevated, no, yung chloride levels, then most probably, no? Then most probably you have cystic fibrosis. So you will see here, no, yung manifestations, pulmonary, gastrointestinal, no? They will also be infertile. No? They will also be infertile. Yung pancreas, no, yung pancreatic insufficiency, kasama din yon. Okay? So even for pedia, you have to study this, ha? Question number 10. A 2-year-old boy, before we go there, ang tatandaan nyo lang, so you will see here, in these other choices, these will all present with recurrent infections, no? Yung CGD, chronic granulomatous disease, yung severe combined immunodeficiency, tsaka X-linked agammaglobulinemia. So remember, yung chronic granulomatous disease, recurrent infection siya, pero anong klaseng infection? Gram-positive organisms, pigsa. Yung severe combined immunodeficiency, this arises from adenosine deaminase deficiency, Hindi lang sila dapat yung mga infection na to na respiratory, all other diseases. Question number 10. A 2-year-old boy was brought to his pediatrician because his parents noted that he would tire easily when playing, often with shortness of breath. On examination, he is tachycardic and pale. He has mild icterus and splenomegaly. CBC showed normocytic anemia with a hematocrit of 24%. Peripheral blood smear showed speculated RBCs and elevated reticulocytes. What is the most likely diagnosis? A. Pyruvate kinase deficiency. B. Pyruvate dehydrogenase deficiency. C. G6PD deficiency. Or D. MCAD deficiency. A 2-year-old boy was brought to his pediatrician because his parents noted that he would tire easily when playing, often with shortness of breath. On examination, he is tachycardic and pale. He has mild icterus and splenomegaly. CBC showed normocytic anemia with a hematocrit of 24%. Peripheral smear showed speculated RBCs with elevated reticulites. What's the most likely diagnosis? Pyruvate kinase deficiency, pyruvate dehydrogenase deficiency, G6PD deficiency, MCA deficiency. So here, the correct answer is, so isipin nyo muna, no? So kung elevated yung reticulocytes and speculated RBCs, ano ibig sabihin nun? So, bagsak yung hematocrit niya, anemic. So, what kind of anemia? This patient has hemolytic anemia, no? So, meron bang sinabing triggers? Wala, no? Wala namang sinabi na triggers. Basta lang may hemolytic anemia. So, anong sagot doon, no? So, pag-iisipan mo lang dito, dalawa. Either yung G6PD deficiency or pyruvate kinase deficiency. Pero, ang sagot dito, pyruvate kinase. Why? Kasi walang trigger na in-specify, no? Tapos wala yung classic bite cells, no? Tsaka Heinz bodies that you see on the peripheral smear. Characteristic of G6PD deficiency. Hindi letter B, kasi letter B, pyruvate dehydrogenase deficiency will present with lactic acidosis, while MCAD deficiency will present with hypoglycemia. So if you remember, no, pyruvate kinase deficiency, so review. So remember yung review natin, no? So yung 3 important steps. Step number 1, which is glucose to glucokinase, glucose 6-phosphate using hexokinase or glucokinase. Step number 3, phosphofructose kinase 1, which converts fructose 6-phosphate to fructose 1,6-bisphosphate. And step number 10, phosphoenol pyruvate to pyruvate catalyzed by pyruvate kinase. Kapag wala yung pyruvate kinase, remember that step generates ATP. So instead of generating 4 ATPs, 2 ATPs na lang in total. And unfortunately, you also invested 2 ATPs in step number 1 and 3. So net ATP 0. So if your cells have net ATP 0, especially red blood cells, they will not be able to maintain the membrane potential. And you will have unstable membranes prone to hemolysis. The opposite of glycolysis will be gluconeogenesis. Recall what are the reversal steps. Pyruvate kinase will be reversed by pyruvate carboxylase and PEP carboxykinase. PFK1, the rate limiting step, will be reversed by fructose 1,6-bisphosphatase. And finally, glucokinase hexokinase will be reversed by glucose 6-phosphatase, which yields now your free glucose, which can be distributed to your other tissues. Question number 11. A 3-month-old infant was taken to her pediatrician because of worsening lethargy. She was born full-term with no perinatal complications, but was always noted to be floppy. On examination, she had poor head control and weak suck. She could not track objects. Okay? She could not track objects. Laboratory exam showed elevated anion gap, elevated lactate, and elevated pyruvate. What is the most likely diagnosis? A. Pyruvate kinase deficiency. B. Pyruvate dehydrogenase deficiency. C. G6PD deficiency. Or D. MCAD deficiency. A 3-month-old infant was taken to her pediatrician because of worsening lethargy. She was born full-term with no perinatal complications, but was always noted to be floppy. Poor head control, weak suck. She could not track objects. Elevated anion gap, elevated lactate, elevated pyruvate. What's the diagnosis? So alam na natin, no? So ito, ano yung mataas? No? Lactate, pyruvate. So may acidosis, no? Hindi siya anemia, acidosis. So yun yung pinaka-keyword doon. So this infant has poor activity with lactic acidosis. So the correct answer there is pyruvate dehydrogenase. So pyruvate dehydrogenase deficiency, it's caused by a buildup of lactic acid. Ang mangyayari dyan, no? There will be buildup of lactic acid. Why? Okay? Why? Kasi si pyruvate, hindi siya makababa. If it cannot go down to acetyl-CoA, it will go up to lactate. No? So it will go up to lactate. Pyruvate will be converted to lactate. Okay, so remember, no, going to the right, pyruvate to oxaloacetate by pyruvate carboxylase, which requires biotin. No? And then pyruvate to ethanol, that's decarboxylation. That happens in fermentation. So please be familiar with this diagram. Number 12, infant na naman. No? A 10-month-old infant was taken to the pediatrician because of failure to achieve milestones. So, puro sila ganyan. No? His weight is low for age. He has poor head control. He cannot sit with support or roll over. And his muscle tone is generally hypotonic. Chest X-ray showed cardiomegaly. Which enzyme or enzymes are most likely to be deficient? A. 4,4-transferase and or 1,6-glucosidase. B. Acid alpha glucosidase. C. Glucose-6-phosphatase. Or D. Skeletal muscle glycogen phosphorylase. A 10-month-old infant was taken to his pediatrician because of failure to achieve developmental milestones. His weight is low for age. He has poor head control. He cannot sit with support or roll over. And his muscle tone is generally hypotonic. Chest X-ray showed cardiomegaly. Which enzyme are most likely to be deficient? A. 4,4-transferase and or 1,6-glucosidase. B. Acid alpha glucosidase. C. Glucose-6-phosphatase. Or D. Skeletal muscle glycogen phosphorylase. So when you look at these choices, these are enzymes for breakdown of glycogen. So we're talking about the glycogen storage disease here. So ano yung buzzword dito? So poor activity, delayed milestones, and cardiomegaly. So yun pala, yun dapat yung clue nyo, no? Yung cardiomegaly. So what affects the heart? It's pump disease. Remember, pump disease affects the pump of the body. And pump disease, what is the enzyme deficiency in pump disease? So you'll see, muscle tone, weak. So hypotonia, cardiomegaly. So alin dyan yung important? Nasaan yung pump disease? It will be your acid alpha glucosidase or acid maltase. So lysosomal acid maltase. Glycogen will accumulate in the lysosomes. No? Glycogen will accumulate in the lysosomes. So let's briefly review the enzymes of glycogen metabolism. So remember, this is your glycogen molecule. If you want to increase the size, palalakihin natin. If you want to grow your glycogen molecule, kailangan natin kabitan ng glucose. Sino magkakabit ng glucose? Sinong yaya niya? Si UDP. What enzyme will create the linear bond? Glycogen synthase. So glycogen synthase creates an alpha-1,4-glycosidic bond. Okay, and attach one glucose residue. You keep attaching glucose residues. Pag marami na, you have your glycogen branching enzyme. The glycogen branching enzyme will introduce an alpha-1,6-glycosidic bond. What about in the fasting state? So in the fasting state, you now have to break down your glycogen. Sino mauna? Kagat, 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 kagat. No? So this is glycogen phosphorylase. Pag apat na lang, titigil na si glycogen phosphorylase. This is now your limit dextrin. Okay, sinong papasok? Your glycogen debranching enzyme. The debranching enzyme will transfer 3 residues. Okay, and then the remaining residues will be released as free glucose. Okay, and then it starts over again. Glycogen phosphorylase again. Remember this table. So again, nasan yung pinag-usapan natin? Pump disease, lysosomal acid maltase. So you see hypotonia, glycogen accumulates in the lysosomes because you do not have you have a deficiency of the acid maltase. So remember the other glycogen storage disorders. So here's the key point. Again, it's not enough for you to memorize the enzyme. You have to be able to answer why. No? You have to be able to explain to yourself, bakit ganun yung symptoms? So let's see here. Question number 13. A 9-month-old infant was taken to his pediatrician for a checkup. His parents noted that his arms and legs don't seem to be growing as fast as his face and abdomen. On examination, he has a protuberant abdomen from an enlarged liver. He also has plaques on his lower extremities and buttocks. Blood glucose level is 28 milligrams per deciliter with elevated lactate, triglycerides, and uric acid. CBC is normal. What is the most likely diagnosis? Cori disease, McArdle disease, pump disease, von Gerth disease. A 9-month-old infant was taken to his pediatrician for checkup. His parents noted that his arms and legs don't seem to be growing as fast as his face and abdomen. On examination, he has a protuberant abdomen from an enlarged liver. He also has plaques on his lower extremities and buttocks. Blood glucose level is 28 milligrams per deciliter with elevated lactate, triglycerides, and uric acid. CBC is normal. What's the most likely diagnosis? Cori disease, myocardial disease, Pompe disease, and von Gerdt disease. So what are the key points here? Number 1, well, infant, ayun na naman, no? Bakit kaya malaki yung abdomen? The abdomen is big because of hepatomegaly, no? So you have hepatomegaly, that's the first clue. Second, when you look at the blood glucose level, it's high, low, normal. It's low, no? So low glucose, that's hypoglycemia. Hypoglycemia and hepatomegaly, right? Ano yung combination na yan? That's von Gerdt disease, no? So remember von Gerdt disease, ano bang deficiencies of von Gerdt? If you go back to the table, no? So von Gerdt disease, you have deficiency of glucose 6-phosphatase. Ano bang role ni glucose 6-phosphatase? That's the final step. Glucose 6-phosphatase is the final step. It's supposed to remove phosphate. Bakit kailangan tanggalin yung phosphate? Para makalabas si glucose. So kung hindi makatanggal si phosphate, hindi makakalabas si glucose. No? Hindi makakalabas si glucose. Pag hindi makalabas si glucose, then you get hypoglycemia. Si glycogen, hindi mo siya ma-breakdown, you have hepatomegaly because you now have glycogen remaining in the liver. Okay? Next, so the correct answer there is von Gerdt disease. How about this one? A 16-year-old male complains of recurrent muscle cramps and weakness of his legs during basketball. So muscles. He noticed that as he plays longer, the symptoms get worse. What's the most likely diagnosis? So Andersen, Hurst, McArdle, von Gerdt. 16-year-old male complains of recurrent muscle cramps and weakness of his legs during basketball. He noticed that as he plays longer, the symptoms get worse. What's the most likely diagnosis? Andersen, Hurst, McArdle, von Gerdt disease. So you see here, walang hypoglycemia. No? Walang hypoglycemia. Muscle weakness lang. So walang hypoglycemia, muscle weakness lang. No? So ano kaya ito? So this will be McArdle disease. No? So this is McArdle disease. Question number 15. No? A medical student supposed to go on an elective in a malaria endemic province was prescribed Primaquine. Shortly after intake of the drug, the student developed pallor and anemia. Which of the following is expected in this patient? A. Glucose 6-phosphate dehydrogenase activity is high. B. Glucose 6-phosphate is low. C. NADPH is high. Or D. Reduced glutathione is low. A medical student supposed to go on an elective in a malaria endemic province was prescribed Primaquine. Shortly after intake of the drug, the student developed pallor and anemia. Which of the following is expected in this patient? A. Glucose 6-phosphate dehydrogenase activity is high. B. Glucose 6-phosphate is low. C. NADPH is high. D. Reduced glutathione is low. So obviously, what are we talking about here? We're talking about glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency. So, di ba, no? So, ang clue doon, no? Drug. You was given a drug, then after the drug, patient developed anemia. Okay? Again, compare earlier, yung pyruvate kinase deficiency, walang trigger. You have to understand, though, that the more common trigger for G6PD deficiency is infection. So, pag may G6PD deficiency, so A obviously is wrong. No? So glucose 6-phosphate dehydrogenase deficiency activity should be low. And letter B, glucose 6-phosphate is low. No? So kung kulang ka sa G6PD, yung glucose 6-phosphate dapat high. No? Kasi hindi mo siya na-metabolize. No? Hindi siya pumupunta doon sa pathway. Actually, wakaw nga lang ang pakialam. No? Letter C, NADPH is high. So remember, G6PD, glucose 6-phosphate dehydrogenase, is part of the first phase. So, yun yung nagpo-produce ng NADPH. So, kung mababa yung activity ni G6PD, NADPH should be low. And letter D, this is the one that's correct. Reduced glutathione is low. Okay, so ano ba nangyari? Again, look, The purpose of the pentose phosphate pathway is to produce NADPH. So in the first phase, NADPH is used to replenish yung reduced glutathione. So kailangan natin ng NADPH to regenerate reduced glutathione kasi it's reduced glutathione, okay, that helps reduce hydrogen peroxide to water. So yung reduced glutathione, yung kailangan natin to neutralize hydrogen peroxide into water. So reduced, magiging oxidized glutathione. So yung oxidized, para bumalik sa reduced, you need NADPH. So ano nangyayari sa pentose phosphate pathway? Walang G6PD. So kung walang G6PD, walang NADPH. Kung walang NADPH, walang reduced glutathione. So kaya that's the correct answer. There's lack of reduced glutathione. The other thing that they also like to ask here is this one, selenium. Selenium is the cofactor of glutathione peroxidase, which reduces hydrogen peroxide to water. So remember, redox reaction. Hydrogen peroxide is reduced. Reduced glutathione is oxidized. Question number 16. An 18-year-old female visits a gastroenterologist because she always experiences diarrhea after drinking coffee with milk in the morning. She also gets cramps and flatulence. The most likely reason for this is deficiency of A. Salivary amylase, B. Pancreatic amylase, C. Small intestinal lactase, or D. Small intestinal isomaltase sucrase. An 18-year-old female visits a gastroenterologist because she always experiences diarrhea after drinking coffee with milk in the morning. She also gets cramps and flatulence. The most likely reason for this is deficiency of A. Salivary amylase, B. Pancreatic amylase, C. Small intestinal lactase, or D. Small intestinal isomaltase sucrase. So this is lactose intolerance. So the lactose intolerance, so the culprit here is milk. So lactose intolerance is deficiency of lactase, no? Where lactase in the intestine. So remember, lactase, the disaccharidases. So lactase, sucrase, maltase, where do you find them? In the brush border. No? So you find them in the brush border of the intestines. Number 17, a 1-year-old boy was brought to his pediatrician because of vomiting and tremors. Symptoms began after he was weaned from breast milk. Since then, he has been drinking powdered milk, Yakult, as well as instant orange and pineapple juice. Physical examination showed hepatomegaly. Laboratory tests showed hypoglycemia and hyperuricemia. His urine was negative for glucose but tested positive for reducing sugars.
Sorry, I didn't get that. Could you restate the question?
Which enzyme is most likely to be deficient? Okay, so 1-year-old boy was brought to his pediatrician because of vomiting and tremors. Symptoms began after he was weaned from breast milk. Since then, he has been drinking powdered milk, Yakult, as well as instant orange and pineapple juice. Physical examination showed hepatomegaly. Laboratory tests showed hypoglycemia and hyperuricemia. His urine was negative for glucose but tested positive for reducing sugars. Which enzyme is most likely to be deficient? Aldolase B, fructokinase,
Okay.
galactose 1-phosphate, uridyl transferase, or D, beta-galactosidase. So you will see here, okay, ano yung keywords natin dito? So what are our keywords here? The keywords are after wean ng breast milk, no? But we don't know what's the culprit, no? So yung milk ba o yung juice, no? Yung milk ba o yung juice? Now, what are the symptoms? So you see, ang crucial dito, positive for reducing sugars. Pag nabasa niyo yung positive for reducing sugars, buzzword na agad yun. No? So, positive for reducing sugars, fructose kasi yung ibig sabihin nun. No? So, what we're dealing with is fructose metabolism disorder. So, alin ba dyan yung fructose metabolism disorder? So, dalawa lang yung choice mo, letter A or letter B. So, either fructokinase or aldolase B. Now, going back, anong sabi natin, no? In the metabolism, in abnormal metabolism of sugars, you have to remember, Kapag step 1 yung missing, the patient has relatively benign symptoms. No? Pag step 2 yung missing, yun yung toxic. So itong patient ba to benign or toxic? Toxic siya, di ba? You have hypoglycemia, hyperuricemia, hepatomegaly. So the correct answer here is deficiency in the second enzyme, which is aldolase B. No? So you must recognize, so ang kasalanan dito yung orange juice at pineapple juice. No? So remember, fructose intolerance, you have hypoglycemia and hyperuricemia. Why do you get hypoglycemia? Because, no, ang nangyayari, this is the deficiency, kukunin ni fructose lahat ng phosphate. No? Fructose will act as a phosphate sink. So, aagawin niya yung phosphate from glycolysis. So, yung glucose walang magamit na phosphate kasi lahat sila na kay fructose. And then it is trapped dito. Natatrap yung phosphate sa fructose 1-phosphate because this step is missing. The other thing we always like to ask, no? So, where does fructose enter glycolysis? Fructose enters glycolysis here in DHAP, no? Dihydroxyacetone phosphate, and glyceraldehyde 3-phosphate. Dito siya pumapasok. How about galactose? Galactose enters here via glucose 6-phosphate. Via glucose 6-phosphate. Okay, so tatandaan ha. So yung fructose, no, hypoglycemia, hyperuricemia, liver failure. Kapag galactose metabolism, ano yung buzzword? Cataracts, no? Cataracts yung buzzword. And then same thing, if step 1 yung missing, galactokinase deficiency, galactosemia, galactosuria lang yon. Pag step 2 yung missing, yung galactose 1-phosphate uridyl transferase or GALT, mas severe yung symptoms. Question number 18. An 8-month-old infant, was taken to the emergency department because she was difficult to awaken after 8 hours of sleeping straight. Over the past few weeks, her parents already noticed that she was becoming more lethargic. In the ER, she had twitching of her arms and legs. Physical examination showed hepatomegaly. She had a blood glucose of 24 milligrams per deciliter, metabolic acidosis with high ion gap, and low ketone bodies. What is the most likely diagnosis? A. Pyruvate kinase deficiency. B. Pyruvate dehydrogenase deficiency. C. G6PD deficiency. Or D. MCAD deficiency. An 8-month-old infant was taken to the emergency department because she was difficult to awaken after 8 hours of sleeping straight. Over the past few weeks, her parents already noticed that she was becoming more lethargic. In the ER, she had twitching of her arms and her legs, so seizures. The physical exam showed hepatomegaly. She had a blood glucose of 24 milligrams per deciliter. Metabolic acidosis with high ion gap and low ketone bodies. What's the most likely diagnosis? A. Pyruvate kinase deficiency. B. Pyruvate dehydrogenase deficiency. C. G6PD deficiency. Or D. MCAD deficiency. So, ano yung clues dito? Infant that's difficult to awaken. So, you see, it's not normal for infants to sleep for 8 hours straight. No? And then look, blood glucose is low. So, hypoglycemia. So, this is a child who's becoming hypoglycemic. Unfortunately, anong mangyayari doon? No? Kaya siya nag-seizures kasi nag-hypoglycemia siya. So, this is, right? Para na tong, ito yung, pag hindi mo to na-address, this will lead to sudden infant death syndrome. So, the diagnosis here is MCAD deficiency. No? So, medium chain acyl dehydrogenase deficiency. In MCAD deficiency, what happens? No? So, in MCAD deficiency, remember, you cannot beta-oxidize short and medium chain fatty acids, which is the predominant component, no, of breast milk. No? So, ang problem, the infants, they cannot undergo beta-oxidation. If they cannot undergo yung medium chain fatty acids, hindi nila ma-breakdown. Pag walang beta-oxidation, walang gluconeogenesis. So during periods of fasting, they become hypoglycemic. Especially infants, hindi naman significant yung stores nila niya ng wala silang storage, hindi sila magaling mag-gluconeogenesis. Why? Immature pa yung enzymes nila, no? Tapos konti lang yung stores nila ng fat. So now, So, tatandaan nyo to, no? MCAD deficiency, isa yan sa postulated reasons for sudden infant death syndrome. Ganito yung history niya, no? So, hypoglycemia, poor activity. No? So, anong treatment dito? How do you treat this? You prevent hypoglycemia. So, you give IV glucose to prevent hypoglycemia. So, hindi sila pwedeng magutom ng matagal, no? So, lagi mo dapat silang i-feed. And ang bibigay mo, wag medium chain fatty acids, dapat glucose. You treat this with IV glucose. Unfortunately, if this is not recognized, hypoglycemic damage yung brain ng mga infants. So, kawawa naman. So, just remember, beta oxidation, no? OHOT, oxidation, hydration, oxidation, thiolysis. It's this first step. The first step is chain length specific, no? May pang short chain, may pang medium chain, may pang long chain. Okay, remember, in the first oxidation step, you require FADH. In the second, you produce FADH. In the second oxidation step, you produce NADH. Beta oxidation na ginagawa natin, this is palmitate. We chop into acetyl-CoA. So, how many times do we have to do it? We repeat OHOT 7 times to generate 8 molecules of acetyl-CoA from palmitate. Okay? Kabaligtaran ng OHOT, code red, no? Fatty acid synthesis. So, code red, condensation, reduction, dehydration, reduction from acetyl-CoA, hahabain naman natin to palmitate. Code red, we repeat 7 times. And every time we undergo reduction, we require NADPH. No? Saan na magagaling si NADPH? Sa pentose phosphate pathway. Right? And with that, we'll take another break. We'll come back with the next set of questions. This is the third part of our biochemistry pearls. Let's go back to our cases. So, question number 19. A full-term newborn infant was noted to have fused labia majora and an enlarged clitoris. On the third day of life, the infant was noted to have failure to thrive. She weighed 300 grams less than her ideal weight. Serum sodium and potassium were low. Serum 17-alpha-hydroxyprogesterone was elevated, but 11-deoxycortisol was low. What is the most likely diagnosis? A. 11-beta-hydroxylase deficiency. B. 21-hydroxylase deficiency. C. 7-dehydrocholesterol reductase deficiency. Or D. phytanol-CoA hydroxylase deficiency. A full-term newborn infant was noted to have fused labia majora and an enlarged clitoris. On the third day of life, the infant was noted to have failure to thrive. She weighed 300 grams less than her ideal weight. Serum sodium and potassium were low. Serum 17-alpha-hydroxyprogesterone was elevated, but 11-deoxycortisol was low. What's the most likely diagnosis? A. 11-beta-hydroxylase deficiency. B. 21-hydroxylase deficiency. C. 7-dehydroxycholesterol reductase deficiency. Or D. phytanol-CoA hydroxylase deficiency. So if we analyze this case, now automatically we will be able to eliminate choice C. Choice C is your Smith-Lemli-Opitz syndrome, this is not the clinical presentation of that, while letter D is Refsum disease. No? So Refsum disease is accumulation, will be accumulation of phytanic acid. You are just left here with choice A and B. No? So what are the clues here? So yung fused labia majora and enlarged clitoris, so that's ambiguous genitalia. So I have a patient with ambiguous genitalia, and then it says here that there's failure to thrive. So she weighed less than 300 grams, her ideal weight. So automatically, so and then what you see here, sodium and potassium are low, and then the hormones, So these hormones, you will see 17-hydroxyprogesterone and deoxycortisol. Automatically, that should give you a clue that this has something to do with your adrenal hormones. Okay? So, ang choice ang natin, 11-beta-hydroxylase or 21-hydroxylase. Alam natin, dito pala, ang katanong na to, this is congenital adrenal hyperplasia. So, typically, so pag congenital adrenal hyperplasia, although wala sa case, so there will be enlargement of the adrenal glands. There will be enlargement of the adrenal glands. And because of deficiency in cortisol, there will be excessive stimulation of your adrenals because of elevated ACTH. So, ang question dito, how do we distinguish 11 beta hydroxylase from 21 hydroxylase? So, the clue here, no? So, remember, kapag 21 hydroxylase, which is the most common form, 21 hydroxylase, wala tayong mineralocorticoid, wala ring glucocorticoid, lahat sila napupunta sa sex hormones. That's why you have the abnormal genitalia. The clue here, no, yung 17-hydroxyprogesterone elevated, that's the screening test. No? That's a screening test for CAH. But the one that will distinguish them will be that the fact that 11-deoxycortisol was low. No, the fact that 11-deoxycortisol was low. So the correct answer here, no, the correct answer here will be 21 hydroxylase deficiency. So you will see here, kung nandito yung block, 21 hydroxylase. Okay. Tataas si progesterone, hydroxyprogesterone, lahat sila pupunta sa sex as steroids. Okay. In contrast, yung 11, kung dito yung block kasi sa 11, no, 11 hydroxylase, your deoxycortisol will not be low. It will be high. No, kasi yung block sa kanya pagkatapos. Kaya alam natin this is 21 hydroxylase deficiency. So what else? How else will you distinguish between the two? If you compare, pag 21 hydroxylase, ay walang deoxycorticosterone. Kasi nga, nandito yung block. So what is the effect of that? Pag 11 hydroxylase, magkakaroon ka na ng deoxycorticosterone. That has a mineralocorticoid effect. So that's why, if it's a 21 hydroxylase deficiency, you will have hypovolemia. Kasi walang fluid retention. Pero kapag 11 hydroxylase, you will have some mineralocorticoid effect already. Okay, you will have some mineralocorticoid already. So they will not be hypovolemic. So they will just be, okay? So remember, classic features pag 21 hydroxylase, hypovolemia, hypoglycemia, and ambiguous genitalia. In contrast, pag 11 hydroxylase, walang hypovolemia, okay, you have hypoglycemia, again, ambiguous genitalia. What else? Because this already has mineralocorticoid effect, no? Renin will already be inhibited. So you will have low renin. No, you will have low renin. And you will have hypertension instead of hypotension. So this table just compares the three. No? So you will see 21 hydroxylase, 11 beta hydroxylase, 17 alpha hydroxylase deficiency. The most common, no, the most common will be this one, your 21 hydroxylase. Okay. And then take note, no, salt wasting. Salt wasting is present in the classic form of 21 hydroxylase. Pero sa 11 hydroxylase, walang salt wasting kasi nga meron ng mineralocorticoid effect yung 11-deoxycorticosterone. Hypertension, wala sa 21 hydroxylase, meron sa 11 hydroxylase. And then you will see, no? So you will see sex steroid deficiency, wala sa 21 tsaka sa 11, meron dun sa 17 alpha hydroxylase. Kasi yun nga yung problem doon, no? So yung papunta sa hormones, sex hormones. Okay. How do you screen neonates? Once again, you screen neonates using the 17-hydroxy. You measure the 17-hydroxyprogesterone levels. So classically, no, so you will have in 21 hydroxylase deficiency, your 17-hydroxyprogesterone level will be high. And then, however, no, you need concentropine stipulation to distinguish classic from mild subtypes. Let's look at this one. At number 20, a newborn infant was diagnosed with congenital adrenal hyperplasia resulting from decreased activity of 11 beta hydroxylase. So you see na binanggit na niya. No? So which of the following is not expected in this patient? A, androstenedione will be high. B, cortisol will be low. C, deoxycorticosterone will be high. D, renin will be high. A newborn infant was diagnosed with congenital adrenal hyperplasia resulting from decreased activity of 11 beta hydroxylase. Which of the following is not expected in this patient? A, androstenedione will be high. B, cortisol will be low. C, deoxycorticosterone will be high. D, renin will be high. So again, so ito naman, 11 hydroxylase. So sabi nga natin kanina, no, pag yung block na dun sa 11, no, so tatandaan nyo, so kailangan natin tignan androstenedione, cortisol, deoxycorticosterone, renin. Okay, so if you look, so yung androstenedione nandito. Okay, So kung ang block natin is here, tataas ba yung androstenedione? No? Tataas ba yung androstenedione? Yes. So your androstenedione will be high. No? So androstenedione will be high. What will happen to deoxycortisol, the 11 deoxycortisol levels? No? It will also be high kasi nandito yung block. So tataas siya. What about, okay? So what about deoxycorticosterone? It will also be high kasi nandito yung block pagkatapos. Pero yung renin, no? Yung renin, what happens? Renin will be low. No? Renin will already be low. Kasi nga dahil meron na itong mineralocorticoid effect, it will feed back to the renin-angiotensin-aldosterone axis. Kaya bababa na yung renin. So that's the correct answer. Renin should be low. No? Renin should be low. Okay? So all of these, no? So all of these are true, no? So you will see. So dahil nandito yung block, tataas to yung deoxycortisol, wala kang cortisol. Tataas yung deoxycorticosterone, masusupress yung renin. Tataas yung androstenedione, maraming sex hormones. Yeah, I know nakakalito siya, no? Pero just remember that, no? So pati yung clinical features. So panaan, yun lang talaga yun, no? To distinguish 21 from 11, yung 21, hypovolemic. Yung 11, hypertensive with low renin. Question number 21. A newborn was noted to have multiple congenital anomalies. She has an extra finger in each hand, a cleft lip and palate, and Hirschsprung disease. She also has low-set ears, drooping eyelids, and a small upturned nose. What is the most likely diagnosis? A. 11 beta hydroxylase deficiency. B. 21 alpha hydroxylase deficiency. C. 7 dihydrocholesterol reductase deficiency. Or D. phytanol CoA hydroxylase deficiency. So alam na natin hindi A and B, no? Kasi yun yung sagot kanina eh. A newborn was noted to have multiple congenital anomalies. She has an extra finger in each hand, a cleft lip and palate, and Hirschsprung disease. She also has low-set ears, drooping eyelids, and a small upturned nose. What's the most likely diagnosis? So we know this infant has multiple congenital anomalies. So maraming organs affected. So with that, no, ano ba yung letter C? Letter C, that's Smith-Lemli-Opitz syndrome in the cholesterol pathway. Letter D, phytanol CoA hydroxylation naman yung sa Refsum disease. The correct answer here is letter C. This is Smith-Lemli-Opitz syndrome. So pag nakakita kayo ng multiple congenital anomalies, yun dapat yung iisipin nyo, ha? So yun yung una nyong iisipin. Yung upturned nose, no? Look, upturned nose, syndactyly, abnormal genitalia. Okay? So the problem here is in cholesterol synthesis, the second to the last step, no? It's the second sorry, it's the last step, hindi pala second to the last step. It's the last step in cholesterol synthesis. So yung 7, right? I also remember that 7 dihydrocholesterol reductase. So the last step in cholesterol synthesis, 7 dihydrocholesterol reductase is missing. And why does it affect all organs? Kasi nga, cholesterol is very important in almost all cells. Question number 22. An 8-year-old was brought to an ophthalmologist because of blurring of vision, especially at night. Examination findings were consistent with retinitis pigmentosa. On further probing, the child also had a poor sense of smell. Ataxia and dry, scaly skin were noted, prompting to a metabolic disease specialist. What enzyme is most likely to be deficient? Of course, by elimination, alam na natin, the answer is letter D, phytanol CoA hydroxylase. So this is Refsum disease. What's the problem with Refsum disease? It's accumulation of phytanic acid. So if you remember, what's phytanic acid? Okay, so phytanic acid undergoes alpha oxidation. Unlike the rest which undergo beta oxidation, phytanic acid alpha oxidation yan. So kung wala kang phytanol CoA hydroxylase, phytanic acid accumulates and it will block beta oxidation. Buzzword for phytanic acid for Refsum disease, retinitis pigmentosa. So Refsum, retinitis pigmentosa. That's a mnemonic. Retinitis pigmentosa. So you will remember REF. Refsum, retinitis pigmentosa. Okay, so neurologic yung symptoms nila. So you will see neurologic yung symptoms. So pag narinig nyo yun, no? Ang isa pa nilang laging tinatanong dito, what fatty acid accumulates in Refsum disease? And the answer is phytanic acid. Question number 23. A 5-year-old boy was brought to his pediatrician because of regression of developmental milestones. He had rapid neurologic decline, eventually slipping into a coma. Upon his death, autopsy showed large amounts of very long-chain fatty acids in his myelin sheath. His adrenal glands were also abnormal. The impaired enzymatic reaction in this patient occurs in which of the following? Golgi apparatus, lysosomes, mitochondria, peroxisomes. A 5-year-old boy was brought to his pediatrician because of regression of developmental milestones. He had rapid neurologic decline, eventually slipping into a coma. Upon his death, autopsy showed large amounts of very long-chain fatty acids in his myelin sheath. His adrenal glands were also abnormal. The impaired enzymatic reaction in this patient occurs in which of the following? Lysosomes, Golgi apparatus, mitochondria, peroxisomes. What's the buzzword here? Very long-chain fatty acids. So remember, so siya, no? So you will see what are the features here. Neurologic. Tapos, so aside from the brain, what's also affected? Adrenal glands. No? So brain and adrenal glands. Tapos very long-chain fatty acids. This is adrenoleukodystrophy. Accumulation of very long-chain fatty acids, adrenoleukodystrophy. Saan ba dapat mabe-breakdown yung very long-chain fatty acids? In the peroxisomes, no? In the peroxisomes. Now, there are several conditions, no? There are several conditions that you need to think of. So this one, kapag walang peroxisomes, anong tawag doon? That's Zellweger syndrome. So Zellweger syndrome, you have no peroxisomes. So you cannot digest very long-chain fatty acids. Sa adrenoleukodystrophy, no, there's a problem in the peroxisomal membrane protein. No? And then you have difficulty transporting the very long-chain fatty acids into the peroxisomes. So, hindi makapunta sa peroxisomes yung very long-chain fatty acids. So, how to distinguish between the two? So, both conditions will result in accumulation of very long-chain fatty acids. Pero si adrenoleukodystrophy, as the name says, meron siyang involvement of the adrenal glands. So, they have adrenal insufficiency. And then sa adrenoleukodystrophy, meron silang peroxisomes. Pero yung transport yung wala. Okay? Transport yung wala. Question number 24. A 25-year-old call center employee was brought to the emergency room after experiencing chest heaviness while talking to a client. The pain radiated to the left shoulder and left arm. Previously, he would experience the same symptoms during exertion, but never this severe. He does not smoke. His maternal grandfather and maternal uncle died of a heart attack below 40 years old. ECG showed ST segment elevation. TROP-I and CK were both elevated. Glucose and uric acid were normal, but triglycerides and LDL were high. What's the most likely diagnosis? A. Familial beta lipoproteinemia. B. Familial hyperalpha-lipoproteinemia. C. Familial hypercholesterolemia. Or D. Familial lipoprotein lipase deficiency. So you have here a 25-year-old who was brought to the emergency room after experiencing chest heaviness. The pain radiated to the left shoulder and left arm. What's that? That's probably MI. So if you have a young patient is probably presumably having an MI. So he had these symptoms before, no? So even if he does not smoke. So that's why here you have segment elevation. So which among these disease conditions will lead to MI? So these are the dyslipidemias, no? Hyperlipidemias. You already know letter D is wrong. No, you already know letter D is wrong. Why? Because familial lipoprotein lipase deficiency, that's type 1. There's no coronary artery disease in type 1. You also already know letter B is wrong because letter B is supposed to be beneficial, no? So beneficial. So ang choice mo nito A or C, no? So obviously the answer is letter C. This is type 2, no? Familial hypercholesterolemia. So in familial hypercholesterolemia, no, so you will see they have accumulation, no, of cholesterol. You have accumulation of cholesterol in the coronary arteries leading to stroke, no? So when do you suspect, no? So this just shows you, no, elevated serum cholesterol. So remember sa type 2, they have elevated LDL and cholesterol, no? So mataas yung cholesterol levels nila. So you suspect type 2 when you have elevated LDL levels and total cholesterol levels, no? They have early cardiovascular disease, tapos may history of early cardiovascular disease in the family. So this just shows you Arcus. When you have elevated cholesterol levels, you also have St. Thomas. So those are cholesterol plaques, no? Those are cholesterol. Even here in the Achilles tendon, no? Even here in the Achilles tendon. Yeah, so anong key feature, no? So remember, no, kapag type 2, so again, remember type 1, walang coronary artery disease. You just have high triglycerides, no? You have high triglycerides, St. Thomas, pancreatitis, but there's no coronary artery disease. Type 2, because walang LDL receptor, si LDL hindi siya makabalik sa liver, so it deposits elsewhere. So you have high LDL and the high cholesterol. So type 4, paano nyo matatandaan si type 4? Type 4, this is associated with metabolic syndrome, no? So associated with type 2 diabetes, coronary artery disease, obesity. So when you think of metabolic syndrome, think familial hypertriglyceridemia type 4. So let's try to see here. Question number 25. A 7-year-old child was brought to the emergency department because of severe abdominal pain radiating to the back. She has had 2 similar episodes in the last year, but this is when symptoms were severe enough to prompt consult. On examination, she has small yellow deposits of fat under the skin of her trunk, buttocks, and arms. Abdominal ultrasound revealed hepatosplenomegaly. Serum triglycerides were elevated, but LDL was low normal. What's the most likely diagnosis? So same choices: familial abeta lipoproteinemia, familial hyperalpha lipoproteinemia, familial hypercholesterolemia, familial lipoprotein lipase deficiency. So you see here, pain radiating to the back, pancreatitis. So first clue. Second clue, you have deposition of fat, no? Yeah, so St. Thomas, no? St. Thomas. And then triglycerides were high, but LDL was low normal. So the correct answer here is lipoprotein lipase deficiency. So you see here, you have St. Thomas on both hands, no? Yung mga yellow. And then when you extract their blood, you see, there's a layering of fat. No? There's layering of fat, suggesting severe, highly elevated triglycerides. So that's lipoprotein lipase deficiency. Take note, no increased risk for coronary artery disease. While applying for a job, an otherwise asymptomatic 32-year-old male was told that his lipid profile showed an HDL level that was above the 90th percentile. What should you consider? So type 1, type 2 hyperlipidemia. So remember, type 1, lipoprotein lipase deficiency. Type 2, so yung type 2 naman, LDL receptor deficiency, triacylglycerolemia. Letter C, hyperalpha lipoproteinemia. D, hypercholesterolemia. The correct answer here is, of course, letter C. So the beneficial one, hyperalpha lipoproteinemia, in which you have elevated HDL, which is actually beneficial for you. Question number 27. A 24-year-old female consults a neurologist because she has a history of blood clots. Her brother died of stroke when he was 18 years old. She is nearsighted and she has had a hard time in school. On examination, she is tall and slender with skinny fingers. Visual acuity is poor and his lens is anteriorly displaced. She has a mild kyphoscoliosis and pectus excavatum. Rest of cardiopulmonary findings are unremarkable. CBC, platelet count, PTT, factor V Leiden, protein C, protein S were normal. Methionine is elevated and cysteine is low. What's the most likely diagnosis? Galactosemia, homocystinuria, methylmalonic aciduria, phenylketonuria. So 24-year-old female with family history of blood clots. No? Brother died of a stroke. So she is tall and slender with skinny fingers. Visual acuity is poor and lens is anteriorly displaced. So yun yung clue. Anterior displacement, anterior or downward displacement of the lens. Okay. And then, sinabi lang dito, anong significance ng protein C and protein S being normal? So this is a patient with stroke in the young. So you need to make sure wala siya no protein C, protein S deficiency. What's the clincher here? High methionine and low cysteine. So that alone should tell you, so we're talking about, so what disease will involve methionine and cysteine? It will be homocystinuria. So, ito yung mga choices, no? So, remember, when you have stroke in the young, you can already here eliminate galactosemia and phenylketonuria because this will not present with stroke in the young. No? Ang stroke in the young, it's either homocystinuria, methylmalonic aciduria, or yung MELAS, which already discussed earlier. No? Wala namang binanggit na mitochondrial disease. No? Wala namang binanggit na mitochondrial disease. So this is either B or C. Between the two, it's homocystinuria that involves your methionine pathway. So look here. So if you remember, methionine is converted to homocysteine, and then homocysteine is converted to cystathionine using cystathionine synthase. And then cystathionine is converted to cysteine. Sa homocystinuria, wala yung cystathionine synthase. So that's why homocysteine accumulates. And this accumulation of homocysteine thickens blood. So it thickens blood, and that's the one that causes stroke. So how do you treat this? You can give B6. When you give B6, you promote the conversion of homocysteine to cystathionine and then cysteine. You avoid methionine. No? So you avoid methionine because if you give more methionine, you'll have more homocysteine. And you supplement cysteine. So that's analogous to phenylketonuria. No? So other things you need to remember, homocysteine can be reconverted back to methionine, but you need methionine synthase, vitamin B12. No? You need vitamin B12. Methionine, as you can see here, no, shuttles, no? So S-adenosyl methionine, yung methyl carriers, no? So you will see the methyl group is transferred to convert phosphatidylethanolamine to phosphatidylcholine. And this choline forms choline, which is part of acetylcholine. So again, maraming intercollection. So, but this is what you need to remember, no? This is what you need to remember. 28, a 24-year-old female with a family history of blood clots consulted a neurologist for screening examination. Because her brother died of stroke at age 17, the neurologist recommended skin biopsy for fibroblast culture, which showed deficient activity of the enzyme cystathionine B synthase. Which of the following should be recommended for this patient? A. Increase methionine in the diet. B. Reduce cysteine in the diet. C. Start treatment with vitamin B1. D. Start treatment with vitamin B6. A 24-year-old female with a family history of blood clots consulted a neurologist for a screening examination. Because her brother died of a stroke at age 17, the neurologist recommended skin biopsy for fibroblast culture, which showed deficient activity of the enzyme cystathionine B synthase. Which of the following should be recommended? So you know right away, we're dealing with homocystinuria, no? So kaya nga binanggit nila, it already mentioned, it's cystathionine B synthase. So stroke in the young, cystathionine synthase. It's just a matter of analyzing, no? So sabi natin, no? So when you look, so will you increase methionine? So imagine in your mind yung diagram kanina. If you have homocystinuria, do you want to increase methionine? No, kasi sobra-sobra na yung methionine. Do you want to reduce cysteine? No, in fact, you want to supplement with cysteine. Do you want to start treatment with vitamin B1? No, B1 has got nothing to do with it. The correct answer is letter D, start treatment with vitamin B6. So again, if you look, you avoid methionine. You don't supplement it. You supplement cysteine, you don't reduce it. So B1, walang silbi, but you can give B6. So vitamin B6, no, somehow will promote conversion of homocysteine to cystathionine kasi it's a cofactor of your cystathionine synthase. Number 29, a 2-week-old infant was admitted in the neonatal ICU because of jaundice, hepatomegaly, and sepsis caused by gram-negative bacilli. His older sister had a similar illness and later developed cirrhosis and cataracts. What's the most likely diagnosis? Galactosemia, homocystinuria, methylmalonic aciduria, or phenylketonuria. A 2-week-old infant was admitted to the neonatal ICU because of jaundice, hepatomegaly, and sepsis caused by gram-negative bacilli. His older sister developed a similar illness and later developed cirrhosis and cataracts. What's the most likely diagnosis? Galactosemia, homocystinuria, methylmalonic aciduria, phenylketonuria. So, mali na yung B and C kasi hindi naman siya stroke in the young, no? Di ba? So, B and C, dapat stroke in the young yung pinipresent dyan or cardiovascular events. So, is it A or D? The correct answer is letter A, galactosemia. What's the buzzword here? Cataracts. No? Cataracts. So, is this a deficiency of the first or the second enzyme. This is a division of the first or the second enzyme. Sabi natin, no, kapag first enzyme yung deficient, benign yung presentation. No, benign yung presentation. So, galactosemia lang yan or galactosuria. But the patient will be relatively benign. So, that's galactokinase deficiency. Pero ito, benign ba? No, severe yung symptoms. So, this is probably deficiency of galactose 1-phosphate uridyl transferase, which is the second enzyme. So pag galactokinase deficiency, okay lang yun, galactosemia lang yun, galactosuria. Pero pag galactose 1-phosphate uridyl transferase deficiency or GALT, then your patient will be more toxic. What's the treatment for this? You avoid galactose and lactose. So this is an absolute contraindication to breastfeeding. Number 30, the parents of a 2-week-old male was advised to see a pediatrician because of an abnormal newborn screening test consistent with phenylketonuria. Which of the following is correct? A, he will exhibit hyperpigmentation. B, his urine will show elevated levels of phenylpyruvate. C, restriction of tyrosine should begin immediately. D, when the child reaches adulthood, discontinuation of dietary restriction is recommended. The parents of a 2-week-old male was advised to see a pediatrician because of an abnormal newborn screening test consistent with phenylketonuria. Which of the following is incorrect? A, he will exhibit hyperpigmentation. B, his urine will show elevated levels of phenylpyruvate. C, restriction of tyrosine should begin immediately. Or D, when the child reaches adulthood, discontinuation of dietary restrictions is recommended. So, kung phenylketonuria, will they exhibit hyperpigmentation? No, in fact, no. They will have fair skin because if you don't have tyrosine, you don't have melanin. So letter B, elevated levels of phenylpyruvate. This is the correct answer, no? Kaya nga siya phenylketonuria. So tataas yung phenylpyruvate, phenyllactate, phenylacetate. Letter C, restriction of tyrosine should begin immediately. No, you don't restrict tyrosine. In fact, you supplement tyrosine. No? Kasi sa phenylketonuria, maraming phenylalanine, walang tyrosine. No? So maraming phenylalanine, walang tyrosine kasi wala yung enzyme. Either wala yung enzyme or you don't have the tetrahydrobiopterin cofactor. Remember this? Sometimes they ask this. What's the cofactor of phenylalanine hydroxylase? About letter D, this is also wrong, no? Because your dietary modification will be for life. So, hindi naman yun nangyayari na pinanganak siya, walang enzyme, paglaki niya, meron na. No, that doesn't happen. If you're not born with it, then most probably will not have it for the rest of your life. So, it is recommended you continue with the dietary modification for life. Number 31, a 4-year-old boy was noted by his parents to have darkening of the urine when it was left standing. He has a normal sibling and there are no other problems. On examination, he has a dark patch on his right earlobe. Which of the following is most likely to be elevated in this patient? Homogentisate, methylmalonate, phenylpyruvate, alpha-ketoisovalerate. A 4-year-old boy was noted by his parents to have darkening of the urine when it was left standing. He has a normal sibling and there are no other problems. On examination, he has a dark patch on his right earlobe. Which of the following is most likely to be elevated in this patient? A, homogentisate, B, methylmalonate, C, phenylpyruvate, or D, alpha-ketoisovalerate. So, yung alpha-ketoisovalerate, no? So, saan yan elevated? That's in MSUD, maple syrup urine disease. No, yung phenylpyruvate sa phenylketonuria. Yung methylmalonate, methylmalonic aciduria. Homogentisate. Okay, saan naman yung homogentisate? Okay. So yung homogentisate oxidase deficiency. Okay. So ang clue dito, no, homogentisate, it's an alkapton body. So since it's an alkapton body, it accumulates in alkaptonuria. So yun yung clue. So ang sagot dito is homogentisate. So remember what happens? Homogentisate cannot be converted to mallyl acetoacetate or mallyl acetoacetic acid. Okay, causing it to accumulate. Homogentisate dioxygenase or homogentisate oxidase deficiency. What's a manifestation? So that's a manifestation. You have darkening of the urine when it is left standing. And then you can have pigment deposition in the joints, in the earlobe, cartilage, and this causes debilitating arthralgias. Otherwise, it's clinically benign. Number 32, a 4-day-old infant was brought to the emergency department because of lethargy and poor suck. On examination, she had sweet-smelling urine. Laboratory workup revealed severe metabolic acidosis. Which of the following will be elevated in this patient's urine sample? Homogentisate, methylmalonate, phenylpyruvate, alpha-ketoisovalerate. A 4-day-old infant was brought to the emergency department because of lethargy and poor suck. On examination, she had sweet-smelling urine. Laboratory workup revealed severe metabolic acidosis. Which of the following will be elevated in this patient's urine sample? So you know what's the diagnosis here? So sweet-smelling urine, lethargy, and poor suck. This is maple syrup urine disease. So what will accumulate in maple syrup urine disease? So I already told this to you earlier. It will be your alpha-ketoisovalerate. So remember, so MSUD, the deficiency is this one. So the second enzyme. So these are your amino acids, valine, isoleucine, and leucine. They will first undergo transamination, your aminotransferases, and then their alpha keto acids. Right? Their alpha keto acids, supposedly they will undergo dehydrogenation. So alpha keto acid dehydrogenase. So supposedly they will be reduced. Supposedly they will be reduced. But what happens, no? So what happens, wala tong enzyme na to. So they will accumulate. So what accumulates in MSUD? Alpha-ketoisovalerate, alpha-ketomethylvalerate, and alpha-ketoisocaproate. So the alpha-keto acids. So tatandaan niyo yan, ha? Minsan tinatanong din nila yon. So what I need to emphasize here is this. The dietary modifications, no? So kapag phenylketonuria, so just a review, I'll highlight the most important ones. Pag phenylketonuria, avoid phenylalanine. Avoid phenylalanine, and then protein restriction, no? So protein restriction, so bawal din ng fish. Bawal din ng fish. Aside from that, kapag MSUD naman, maple syrup urine disease, so bawal yung leucine, isoleucine, and valine. Sa homocystinuria, bawal ang methionine. So you will see here, you will give vitamin B6. You will give vitamin B6 kasi nga that promotes conversion of homocysteine to cystathionine. Okay, so sa tyrosinemia, type 2, you give omega-3 fatty acids. Ibang common dito. So pyruvate dehydrogenase deficiency, you give a ketogenic diet, high-fat diet. Why? Kasi you cannot convert pyruvate to acetyl-CoA, di ba? So para makakuha tayo ng acetyl-CoA, you'll give a high-fat diet. Okay? So again, take note of this. No? Take note of this. So remember kung ano yung tumataas, no? So you need to supplement kung ano yung kulang. So you will see here pag arginosuccinic aciduria at argininemia, because you do not have arginine, you need to give arginine. So remember that, ha? And again, take note, ano pa yung mga kailangan nyo i-take note. Minsan, ang nasa choices, actual food products, no? So what will you give this patient? Bananas, you will give fish, you will give legumes, yung mga ganun, no? So I will leave it up to you to study those things. Question number 33. A 5-month-old infant was referred to an orthopedic surgeon because of limb shortening and bowing of his long bones. He had an unremarkable perinatal course, but on his 4th month of life, he developed a fracture of the right humerus. His sclerae are blue. Chest examination is unremarkable. His skin is thin and translucent, showing many bruises. His parents deny any form of abuse and disclose that other relatives has got the same symptoms at a young age. What protein is abnormal in this patient? Type 1 collagen, type 3 collagen, elastin, or fibrillin. A 5-month-old infant was referred to an orthopedic surgeon because of limb shortening and bowing of his long bones. He has had an unremarkable perinatal course, but on his 4th month of life, he developed a fracture of the right humerus. His sclerae are blue. Chest examination is unremarkable. Skin is thin and translucent, showing many bruises. His parents deny any form of child abuse and disclose that other relatives had the same symptoms at a young age. What is abnormal? So what's her diagnosis first? So Okay, so abnormality of the bones, fracture, and blue sclerae. So yun yung buzzwords dyan. So blue sclerae, multiple fractures, and relatives with the same symptoms, probably this is probably autosomal dominant. This is osteogenesis imperfecta, problem with type 1 collagen. So remember, where do you find type 1? Bone, tendon, fascia, no? So tough structures. Number 34, a 14-year-old female consulted a neurologist because of persistent headache. She experiences pain almost daily, sometimes awakening her at night. She said that she gets bruises easily and her gums often bleed when brushing her teeth. On examination, her skin was elastic and the joints of her extremities were lax. What should you consider? Alport syndrome, Ehlers-Danlos loss, epidermolysis bullosa dystrophica, osteogenesis imperfecta. A 14-year-old female consulted a neurologist because of persistent headache. She experiences pain almost daily, sometimes awakening her at night. She said that she gets bruises easily and her gums often bleed when she's brushing her teeth. On examination, skin was elastic and the joints were extremely lax. What should you consider? Alam na natin hindi D, kasi D, yun ay kanina, no? Brittle bone disease, multiple fractures dapat yun, tsaka blue sclerae. Alam din natin hindi C, because if it's C, epidermolysis bullosa dystrophica, what happens here? The skin sloughs off easily. No? Eh ito, elastic lang yung joints niya, hyperflexible. So letter C, the problem there is type 7 collagen, which anchors the epidermis of the dermis. So the correct answer is letter B, or Ehlers-Danlos. No? Ehlers-Danlos. So hyperflexible joints. No? So number 35, a 5-month-old infant was brought to a pediatrician for poor weight gain. On examination, he has mild icterus, as well as frontal bossing and hepatosplenomegaly. Laboratory workup revealed microcytic anemia and a low reticulocyte count. Hemoglobin electrophoresis revealed markedly decreased hemoglobin A. Hemoglobin F was 70% of total hemoglobin. What's the total diagnosis? Alpha thalassemia, beta thalassemia, hereditary spherocytosis, sickle cell disease. 5-month-old infant was brought to a pediatrician for poor weight gain. On examination, he has mild icterus, as well as frontal bossing and hepatosplenomegaly. Laboratory workup revealed microcytic anemia and a low reticulocyte count. Hemoglobin electrophoresis revealed markedly decreased hemoglobin A. Hemoglobin F was approximately 70% of total hemoglobin. What's the most likely diagnosis? So, anong clue dito? So, this patient has anemia and hepatosplenomegaly. Ibig sabihin, nag-hemolysis siya, no? The patient probably has repeated episodes of hemolysis. But ano pa yung clue? Meron daw siyang hemoglobin A. Decreased lang. No? So ano ba yung hemoglobin A? Alpha-alpha, beta-beta. And then hemoglobin F was approximately 70%. Ano ba yung 70%? What's hemoglobin F? Alpha-alpha, gamma-gamma. So maraming alpha-alpha, gamma-gamma, konting-konti yung alpha-alpha, beta-beta. So ano kaya yung kulang? Is it the alpha chain or the beta chain? Then it's a beta chain. So the correct answer here is beta thalassemia. No? So yun yung tatandaan nyo sa thalassemias, kung anong pangalan, yun ang kulang. No? So kung kulang ng beta chains, beta thalassemia yun. What's the other clue here? The clue here is it's a 5-month-old infant. Beta thalassemia usually presents later on in life, mga 6 months, around 6 months. Because when you're born, you don't need beta chains yet kasi nga marami tayong hemoglobin F. Just remember, hemoglobin A is alpha, alpha, beta, beta. That's 90% of your hemoglobin. Hemoglobin F is alpha, alpha, gamma, gamma. So this is when you're born, you have hemoglobin F. Eventually, it goes down as hemoglobin A goes up. You must remember again, we all have HbA1c, which is the glycated glucose, 3 to 9%. A 27-year-old female consulted a pulmonologist because of worsening dyspnea. She does not smoke. Her siblings also complain of mahina ang baga. There's no family history of tuberculosis. Chest X-ray findings were consistent with emphysema involving both lungs. Which of the following will explain this patient's symptoms? A. Deficiency in alpha-1 antitrypsin. B. Deficiency in elastase. C, deficiency in vitamin C. D, deficiency in prolyl hydroxylase. A 27-year-old female consulted a pulmonologist because of worsening dyspnea. She does not smoke. Her siblings also complain of mahina ang baga. There's no family history of tuberculosis. Chest X-ray findings were consistent with emphysema of both lungs. What will explain the symptoms? So emphysema, but not a smoker. So that's alpha-1 antitrypsin deficiency, no? So this is alpha-1 antitrypsin in which there's deficiency of alpha-1 antitrypsin. Hindi pwedeng deficiency in elastase. So remember, si elastase yan yung culprit. Elastase is the one that cuts off the alveolar wall. Siya yung gumugupit. No? So actually, excessive activity of elastase yan. Deficiency in vitamin C, walang kinalaman dito. Prolyl hydroxylase, wala rin kinalaman dito. No? So pang distractors lang yan. C and D refer to collagen. C and D refer to collagen. So again, take note, lang alveolus, excessive activity, no, of elastase. So you need alpha-1 antitrypsin to prevent elastase from destroying the lung parenchyma. Number 37, a 2-year-old child was brought to the emergency department because of vomiting and irritability. He has had viral symptoms for the past 3 days. He had similar episodes before, but this is the most violent he has become. He is febrile, tachycardic with other signs of dehydration. On examination, he has hyperreflexia, a mild flapping tremor when his hands are hyperextended, and a positive Babinski sign. Serum ammonia and urine orotic acid levels are elevated. What is the most likely diagnosis? A, arginine-succinate lyase deficiency. B, arginine-succinate synthetase deficiency. C, carbamoyl phosphate synthetase 1 deficiency. Or D, ornithine transcarbamylase deficiency. A 2-year-old infant was brought to the emergency department because of vomiting and irritability. He has had viral symptoms for the past 3 days. He had similar episodes before, but this is the most violent he has become. He is febrile, tachycardic with other signs of dehydration. On examination, he has hyperreflexia, a mild flapping tremor when his hands are hyperextended, and a positive Babinski sign. Serum ammonia and urine orotic acid levels are elevated. What's the most likely diagnosis? So when you look at the choices, these are enzymes of the urea cycle. That's why when you look at the clinical presentation, so asterixis, very classic for hyperammonemia. No? So sabi natin, yung mga urea cycle disorders, all of them will present with hyperammonemia. No? So don't even try to distinguish them from each other based on symptoms. Kasi nakita nyo, neurologic deficits, asterixis, no? Hyperammonemia yan. So, ang magkakatalo na lang sila kung anong elevated. So, in this patient, ammonia is high, which is expected for all, and urinary orotic acid levels are high. That's the clue. Elevated orotic acid. And because of that, we know the answer is ornithine transcarbamylase, which is actually the most common enzyme deficiency in the urea cycle. Take note, urea comes from ammonia, aspartate, and carbon dioxide. If you have elevated ammonia, but you don't have the urea cycle, then you will have hyperammonemia. So take note, if you have deficiency in ornithine transcarbamylase, what will happen? What will become elevated? It will be carbamoyl phosphate. No? Kasi ornithine transcarbamylase catalyzes, no, yung carbamoyl phosphate plus ornithine. So if you don't have this, carbamoyl phosphate will be high. And the carbamoyl phosphate will go to pyrimidine synthesis. And pyrimidine synthesis will go to synthesis, will promote. So in pyrimidine synthesis, you will have elevated levels of orotic acid, which is a pyrimidine. That's why the answer is OTC. So tandaan nyo yun, ha? Sa OTC, ang mataas, orotic acid, kasi dito yung block. Let's compare. On the second day of life, an infant born at home was brought to the emergency department because of PURSA, vomiting. He was lethargic, tachypnic, and hypothermic. Serum ammonia levels were markedly elevated. What's the diagnosis? So same choices. Arginine-succinate lyase deficiency, arginine-succinate synthetase deficiency, deficiency of carbamoyl phosphate synthetase 1, ornithine transcarbamylase. So alam natin, hindi na letter D. So when you look, ano ba yung mataas? Just ammonia, nothing else. Just ammonia, nothing else. And you will see very young patients, so very severe. So among all the hyperammonemias, what is most severe? The most severe is yung type 1. So CPS1 deficiency. So carbamyl phosphate. So if you look, this is a deficiency dahil nandito yung block. What will be high? Ammonia. Kasi yun lang naman yung mabablock. Hindi na siya maka-push forward. Kaya ammonia yung mataas. No? Kaya ammonia yung mataas. Question number 39. A 3-year-old infant has episodic lethargy and vomiting. He was brought to the emergency department because he subsequently had seizures. Laboratory exam showed elevated ammonia and arginosuccinate. What is the most likely diagnosis? So same choices. Alam na natin hindi C and D kasi yun yung sagot kanina. You have either arginosuccinate lyase or arginosuccinate synthetase. So between the two, which one will have elevated ammonia and arginosuccinate? So saan tataas yung arginosuccinate? Pag yung block, yung kasunod na enzyme, so the correct answer here is A. So when you look, arginosuccinate synthetase is here. No? So you will see arginosuccinate synthetase is here. Arginosuccinate lyase is here. So pag nandito yung block sa arginosuccinate synthetase, anong tataas? Citrulline. Pag arginosuccinate lyase yung deficiency, anong tataas? Arginosuccinate. That's why this is the correct answer. Arginosuccinate lyase deficiency. Kasi kung synthetase, anong tataas? Citrulline. Question number 40. A 32-year-old female experiences episodes of disorientation, hallucinations, and paranoia. She was initially referred to psychiatry, who noted that during these episodic attacks, she also had abdominal pain. Laboratory testing revealed elevated porphobilinogen and delta-aminolevolinate. What's the most likely diagnosis? A. Acute intermittent porphyria. B. Congenital erythropoietic porphyria. D. Porphyria cutanea tarda. D. Variegate porphyria. A 32-year-old female experiences episodes of disorientation, hallucinations, and paranoia. She was initially referred to psychiatry, who noted that during these attacks, she also had abdominal pain. Lab testing revealed elevated porphobilinogen and delta-aminolevulinic acid. What's the most likely diagnosis? A. Acute intermittent porphyria. B. Congenital erythropoietic porphyria. C. Porphyria cutanea tarda. Or D. Variegate porphyria. So you see, we're choosing between the porphyrias. What's the crucial point here? Wala siyang photosensitivity, di ba? Neuropsychiatric symptoms lang and abdominal pain. And then what's accumulating? Just ALA and PBG. So alam natin, wala pa tong porphyrin ring. No? So this patient, no? So walang porphyrin ring. So the correct answer here is acute intermittent porphyria. So you will see, no? So this is acute intermittent porphyria. Yung mga porphyrias, sabi natin, we divide it into two. No? You divide whether you have photosensitivity or not. In acute intermittent porphyria or porphobilinogen deaminase deficiency, the block is here. So ang tataas lang ay delta-aminolevulinic acid and porphobilinogen. You don't have the porphyrin ring yet, kaya wala siyang photosensitivity sa symptoms. No? That's why you don't have photosensitivity in the symptoms. So, huwag niyo kakalimutan, no? So, among these ones, yung walang photosensitivity, AIP yung dapat yung matandaan. So, usual history, diagnosed as psychiatric condition. Well, let's compare with this one. A 54-year-old male presented with painful blisters on the back of his hands and neck. Ting, 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 photosensitivity. This began after he started running outdoors a couple of weeks ago. Sabi na sa'yo, photosensitivity. He denies using any new soaps, detergents, or medications. There was no known exposure to any allergen. He had been on phenytoin for 2 years now for seizure disorder. Skin culture did not show any organism, so this is not infectious. 24-hour urine showed elevated uroporphyrin at 1,200 milligrams. What's the most likely diagnosis? Acute intermittent porphyria, congenital erythropoietic porphyria, porphyria cutanea tarda, or variegate porphyria. 54-year-old with painful blisters on the hands blisters on the back of his hands and nape. This began after he started running outdoors a couple of weeks ago. He denies using any new soaps, detergents, or medications. There was no exposure to any known allergen. He had been on phenytoin for 2 years now for seizure disorder. Skin culture did not show any organism. 24-hour urine showed elevated uroporphyrin at 1,200 milligrams. What's the most likely diagnosis? So the correct answer, so you will see, anong keywords ito? Photosensitivity. The elevated metabolite is uroporphyrin. This is porphyria cutanea tarda. So when you look, porphyria cutanea tarda is here. Okay? So uroporphyrinogen decarboxylase. So if your block is here, no? So dito yung block, kaya ang tumataas, uroporphyrinogen. So uroporphyrinogen, which will be converted to uroporphyrin. So dun kaya crucial, no? Kaya crucial na alam nyo kung ano yung nawawala, ano yung mag-accumulate. Okay? So next, a 12-year-old boy was brought to a dermatologist because of skin that blisters easily. His urine also darkens on standing and he has stained teeth. Laboratory workup revealed elevated uroporphyrin 1 and coproporphyrin 1 in blood. Uroporphyrin 1 was also seen in the urine. What's the most likely diagnosis? So let's compare. So ito daw, no, skin photosensitivity. So the correct answer is congenital erythropoietic porphyria. Why? So if the block is here, hydroxymethylbilin yung mag-accumulate. That hydroxymethylbilin is converted to uroporphyrinogen, which is the one that accumulates in the urine. Okay? Which is the one that accumulates in the urine. So that's why, look, uroporphyrin 1, no, and coproporphyrin 1. No. So you will see, pag tumaas si hydroxymethylbilin, pupunta siya doon, no? Hindi ito. Pero kunyari, sinabi ko, no, ang nag-accumulate uroporphyrinogen 3, then it's not this one, it's the next enzyme, yung porphyria cutanea tarda. So once again, no, very important na kailangan alam niyo yung sequence ng metabolites. So you have an idea what's the enzyme missing, what's the diagnosis. Number 43, a 3-month-old infant. A 3-month-old infant was brought to a pediatrician because of failure to thrive. Kawawa naman yung mga batang to. He has hepatosplenomegaly. Dermatan sulfate and heparan sulfate are both elevated in the urine. He does not have a dazzle reflex, and ophthalmologic examination confirmed corneal clouding. What is the enzyme deficiency? A. Beta-glucuronidase. B. Beta-galactosidase. C. Alpha-L-iduronidase. Or D. Iduronate sulfatase. No? 3-month-old infant was brought to a pediatrician because of failure to thrive. He had hepatosplenomegaly. Dermatan sulfate and heparan sulfate are both elevated. He does not have a dazzle reflex, and ophthalmologic exam confirmed corneal clouding. What is deficient? So when you hear of dermatan sulfate and heparan sulfate, you know these are glycosaminoglycans. So this disease we're talking about is elevation of glycosaminoglycans, also known as mucopolysaccharidosis. So dun sa mucopolysaccharidosis, no, sino yung abnormal facial features and corneal clouding? So dalawa sila, di ba? Either Hunter or Hurler. So between Hunter and Hurler, sino yung malabo yung mata? Malabo yung mata yung Hurler. No? Madamo yung mata yung Hurler. And sa Hurler syndrome, ano ang deficiency? Iduronidase. So alpha-L-iduronidase. Pag Hunter, iduronate sulfatase. Pag Hunter, iduronate sulfatase. But both of these conditions will lead to elevated dermatan and heparan sulfate. So tandaan nyo lang, hunted. So hunted or hurled, H and D, di ba? So heparan and dermatan sulfate yung nag-accumulate sa kanila. Number 44, a 5-year-old boy is often teased in school because of his coarse facial features and short stature. On consult with the pediatrician, he was also noted to have corneal clouding and hearing loss. His parents disclosed that he has recurrent episodes of upper respiratory infections. His IQ is normal for age. What's the most likely diagnosis? Hunter syndrome, Hurler syndrome, Morquio, or Sly syndrome? So 5-year-old boy teased in school because of coarse facial features and short stature. On consult with the pediatrician, he was noted to have corneal clouding and hearing loss. Normal yung IQ, no? So abnormal facial features but normal IQ. So among the mucopolysaccharidosis, which one will have no CNS involvement? The correct answer is Morquio. So remember that, no? So si Morquio, no, pwedeng abnormal yung facial feature, short stature, but normal, hindi involved yung CNS. Okay, this one is Hunter and Hurler. So you will see both Hunter and Hurler will also have coarse facial features because of accumulation of mucopolysaccharides in connective tissue. Hunter will have walang corneal clouding. Hurler will have corneal clouding. Question number 45. An 8-month-old infant was brought to a pediatrician because of developmental delay. He is less active compared to children of his age. On examination, he has fair activity and decreased muscle tone. He cannot roll over or sit with support. Physical examination of the chest and abdomen was unremarkable. Because of a high index of suspicion, a cherry red, he was referred to an ophthalmologist who documented a cherry red spot on fundoscopy. Which of the following enzymes is most likely to be deficient? Hexosaminidase A, sphingomyelinase, beta-galactosidase, or beta-glucosidase. So 8-month-old infant brought to a pediatrician because of developmental delay. He has fair activity, decreased muscle tone. He cannot roll over. So delayed talaga for an 8-month. So unremarkable chest and abdomen, which means no hepatosplenomegaly. However, there's a cherry red spot. So those are the clues. Cherry red spot, but no hepatosplenomegaly. What's the diagnosis? It's Tay-Sachs. So in Tay-Sachs disease, what's the enzyme deficiency? It's hexosaminidase A. So remember, no? So this is for your sphingolipids, you want to break them down back to ceramide. So for example, no? So si Tay-Sachs, you have GM2 ganglioside. This will be broken down by hexosaminidase A. Right? This will be broken down by hexosaminidase A. So if you don't have hexosaminidase A, then GM2 ganglioside will accumulate. Gaucher's disease, you're supposed to break down glucocerebroside. So who will do that? Beta-glucosidase. No? Kung wala kang beta-glucosidase, wala. Mag-accumulate yung glucocerebroside. Then you have Gaucher. Niemann-Pick, you don't have sphingomyelinase. No, you don't have sphingomyelinase. So sphingomyelin accumulates. So remember, in Tay-Sachs, include on, cherry red spot, but no hepatosplenomegaly. So clue there, yung clue, no, para hindi kayo malito. Remember, Taylor Swift. No, Taylor Swift. No, si Taylor Swift, wala siyang hepatosplenomegaly. But may red. Meron siyang album na red. Di ba? So, meron siyang red. May cherry red spot. No? So, that's why. Tay-Sachs, no hepatosplenomegaly, but cherry red spot. Okay, what else? You will see, what do you see? Under the microscope, you have lysosomes with onion skin. No? So, lysosomes with onion skin from accumulation of GM2 ganglioside. How about for Niemann-Pick? So for Niemann-Pick, you see this, okay, foam cells. So Niemann-Pick, sphingomyelinase deficiency. So sphingomyelinase sa Niemann-Pick, you have hepatosplenomegaly. So that's a difference. Hepatosplenomegaly with cherry red spot, that's Niemann-Pick disease. 12-year-old, number 46, a 12-year-old Caucasian was brought to a pediatrician because of leg pain, especially at night with fatigue. On examination, he was noted to have an enlarged liver and spleen. Ophthalmologic exam was unremarkable. Which of the following enzymes is most likely to be deficient in this patient? So same choices. So hexosaminidase A, sphingomyelinase, beta-galactosidase, beta-glucosidase. A 12-year-old Caucasian was brought to a pediatrician because of leg pain, especially at night, associated with fatigue. On examination, he was noted to have enlarged liver and spleen. Of the exam was unremarkable. So, hepatosplenomegaly, no cherry red spot. But with leg pain. Okay, with leg pain. So, saan yan? This would be Gaucher's disease. No? So sa Gaucher's disease, very characteristic yan yung bone pain. So the enzyme deficiency is beta-glucosidase. So here, this is your crumpled tissue paper. So these are Gaucher cells. These are macrophages that look like crumpled tissue paper. They will have hepatosplenomegaly because of accumulation of glucosylceramide, but there's no cherry red spot. This just shows you the Erlenmeyer-Flass femur, no? They will have bone erosion, no? So that's very characteristic of Gaucher's disease. So that's the end of the third part. Let's take a break. Okay, so let's go to the last part of your biochemistry pearls. So we'll just continue with the cases. Question number 47. A 9-month-old infant was brought to a pediatrician because of high fever and colds that started 3 days ago. Her parents said that she has had 6 or 7 such episodes now, but this time she appears much sicker. She also had diarrhea a couple of weeks ago. On examination, she is febrile and tachypnic. She has fallen off the growth curve from 70th percentile in her 6th month down to the 20th percentile for age. Crackles and harsh breath sounds are most prominent in the left lung field. CBC showed consolidation in the left lower lobe. Which of the following enzymes is most likely to be deficient? A. Adenosine deaminase. B. Hypoxanthine guanosine phosphoribosyl transferase. C. Orotidine phosphate decarboxylase. Or D. Ribonucleotide reductase. A 9-month-old infant was brought to a pediatrician because of high fever and colds that started 3 days ago. Her parents said that she has had 6 or 7 such episodes now, but this time she appears much sicker. So you have recurrent infection or recurrent respiratory tract infection and diarrhea. She is febrile and tachypnic, and then she has fallen off the growth curve from 70th to 20th percentile for age. So there's also stunting, no? There's also decrease in weight, no? So there's also malnutrition, presumably from the chronic illness. Crackles and harsh breath sounds. CBC showed normal WBC count, CBC and low lymphocyte count. So low lymphocytes. No? So what are the clues here? So you have recurrent respiratory tract infection, low lymphocytes. So when you look at the choices, so these enzymes, so letter D, we don't have a disease associated with that. Between A, B, and C, letter B, HGP-RT deficiency, that will manifest as, what's the diagnosis if you have HGP-RT deficiency? That's Lesch-Nyhan. So this is not Lesch-Nyhan. So obviously this is just A or C. So letter C, orotic deaciduria, it will not present like this. The answer here is letter A. So what are we dealing with here? So adenosine deaminase deficiency, so you cannot convert adenosine to inosine. So what's the problem? No, so this presents as severe combined immunodeficiency. So why? So why does that happen? When you have adenosine deaminase deficiency, adenosine builds up, and the high levels of deoxy adenosine ADP will actually inhibit your ribonucleotide reductase. The lymphocytes are most affected. No? So the lymphocytes are most affected. So your both B and T lymphocytes are affected. Aside from that, you can also have skeletal abnormalities, neurodevelopmental delay, and pulmonary manifestations as shown in the case. So they have persistent infection. So remember, no, kapag ganyan, no, so always think of adenosine deaminase deficiency. So bubble boy, no, yung bubble boy, siya yun. Number 48, a 3-year-old child was brought to his pediatrician because of persistent biting of his fingers. He also likes to bang his head on the wall for no reason. He is wheelchair-borne and he has developmental delay. Laboratory testing confirmed hyperuricemia. Which of the following enzymes is most likely to be deficient? So same choices. So 3-year-old, because of persistent biting of the fingers, likes to bang his head on the wall. So that's self-mutilation. No? Self-mutilation with hyperuricemia, the diagnosis will be Lesch-Nyhan syndrome. And the enzyme deficiency is Letter B, hypoxanthine guanosine phosphoribosyl transferase. So remember, supposedly you're supposed to break down all purines into uric acid, but then you can recycle it. So you can recycle it. How do you recycle it? So guanine can be converted back to guanilic acid, GMP. Hypoxanthine can be converted back to inosinic acid. So this is through HGPRT. APRT will recycle adenine. So in Lesch-Nyhan syndrome, you do not have HGPRT. So they don't really know why you get self-mutilation. But obviously, if you cannot recycle hypoxanthine and guanine, you'll have buildup of uric acid. 49. A 51-year-old male undergoing chemotherapy for cancer develops pain in the metatarsalophalangeal joints of his right big toe. On aspiration of his joint fluid, monosodium urate crystals are seen by polarized light microscopy. His symptoms are due to overproduction of the end product of each of the following. A. De novo purine synthesis. B. De novo pyrimidine synthesis. C. Purine salvage pathway. Or D. Purine degradation pathway. A 51-year-old male undergoing chemotherapy for cancer develops severe pain in the metatarsalophalangeal joint of his right big toe. On aspiration of his joint fluid, monosodium urate crystals are seen by polarized light microscopy. His symptoms are due to overproduction of the end product of each of the following. So you see, this is simply gout. No? So this is gout. And when you have gout, that's accumulation of uric acid, correct? So as we've shown earlier, accumulation of uric acid, this is purine degradation pathway. So you're supposed to degrade purines all into uric acid. If you have gout, you have excess levels of uric acid, you can inhibit xanthine oxidase using febuxostat or allopurinol. No, this will inhibit xanthine oxidase. What's the difference between purines and pyrimidines? Remember that in the purines, you cannot bring down the purine ring most of the time. In contrast, your pyrimidine ring can be broken down into water-soluble products. That's why it's very rare for you to hear of pyrimidine accumulation disorders. Number 50, a 2-year-old child is noted to be weak and anemic. Her height and weight are now low for age, and urine showed elevated levels of orotic acid. Which of the following pathways is impaired in this patient? A. De novo purine synthesis. B. De novo pyrimidine synthesis. C. Purine salvage pathway. Or D. Purine degradation pathway. A 2-year-old child is noted to be weak and anemic. Her height and weight are low for age, and urine showed elevated levels of orotic acid. Which of the following pathways is impaired in this patient? So you see here, orotic acid. We know that orotic acid, orotidine monophosphate, is the parent pyrimidine. So if it's accumulating, that means there's a block in the pyrimidine pathway. So the correct answer here is pyrimidine synthesis. So remember the comparison between purine and pyrimidine synthesis. No? So this is very important. So for purine synthesis, remember it has more ingredients. Glutamine aspartate carbon dioxide plus glycine and tetrahydrofolate. So you will see here when you look at the diagram, now you will see, so aside from glycine, aspartate, and carbon dioxide, which are common for, not glycine, but glutamine, aspartate, and carbon dioxide, which is common for the two, your purine ring will have glycine and tetrahydrofolate. Okay? Then purine will have 2 rings, compared to pyrimidine, just 1 ring. The rate-limiting step is PRPP glutamyl amidotransferase for purines, CPS2 for pyrimidines. What else? In purine synthesis, the sugar comes first. Purine, sugar comes first. No? So you create the ribose 5-phosphate, convert it to PRPP, and then construct the ring. For pyrimidines, it's the opposite. You create the ring first, and then when it's done, you attach ribose phosphate, again using PRPP. Purine synthesis will produce G and A. Pyrimidine synthesis will produce C, U, and T, cytosine, uracil, and thymine. Number 51, an 8-year-old girl was brought to a dermatologist because she is excessively sensitive to sunlight. She has many freckles on sun-exposed parts of her body, and she has 2 lesions on her face which showed basal cell carcinoma on biopsy. Which of the following is most likely to be defective in this patient? A. Removal of pyrimidine dimers from DNA. B. Removal of uracil from DNA. C. Repair of double-strand breaks. D. Repair of mismatched strands. An 8-year-old girl was brought to a dermatologist because she is excessively sensitive to sunlight. She has many freckles on sun-exposed parts of her body, and she has 2 lesions on her face, which showed basal cell carcinoma on biopsy. Which of the following is most likely to be defective? A. Removal of pyrimidine dimers. B. Removal of uracil. C. Repair of double-strand breaks. Or D. Repair of mismatched strands. We are here talking about xeroderma pigmentosum. And for xeroderma pigmentosum, what's the problem? You cannot remove thymine dimers. So the correct answer here is letter A. So when you expose the DNA to sunlight, to UV, the adjacent thymines, right, they will form a dimer, and that prevents DNA replication. So the treatment here is to avoid UV exposure. Compared with this one, a 35-year-old male was noted to have right-sided mucinous colon cancer on screening colonoscopy. There were no other polyps seen. His father and paternal uncle were also previously diagnosed with colon cancer, which is most likely to be defective. So same choices, no? So colon cancer at a young age, no? And then similar relatives with same diagnosis. So remember, no? So this is hereditary non-polyposis colon cancer. No? So that's why no other polyps. That's a clue there. So hereditary non-polyposis colon cancer. This is repair of mismatched strands. So this is Lynch syndrome. So in HNPCC, this is seen mainly in older patients with fewer polyps. While on a picnic, a family decided to include some wild mushrooms in their salad, after which all of them became ill. Which of the following enzymes was most likely inhibited? DNA gyrase, DNA ligase, DNA polymerase 3, RNA polymerase 2. While on a picnic, a family decided to include some wild mushrooms in their salad, after which all of them became ill. Which of the following enzymes was most likely inhibited? DNA gyrase, DNA ligase, DNA polymerase 3, RNA polymerase 2. The correct answer here is RNA polymerase 2. So ano kayang mushroom yon? This is your Amanita mushrooms. So your Amanita mushrooms, remember, they inhibit RNA polymerase 2. Or what does RNA polymerase 2 produce? So RNA polymerase 2 will produce RNA. Kaya nga siya RNA polymerase. Which RNA predominantly? So remit RMT. So that's mRNA, no? Kasi 'di ba RMT, RNA for polymerase 1, mRNA for polymerase 2, tRNA for polymerase 3. What does DNA polymerase 3 produce? DNA, no? What does DNA ligase do? It seals the final bond, no? It seals the final nick. DNA gyrase, what does DNA gyrase do? Gyrase is topoisomerase 2. Number 54, a bacterial mutant grows normally at 32 degrees, but at 42 degrees accumulates short segments of newly synthesized DNA. Which of the following enzymes is most likely defective at the non-permissive temperature, no? So you will see, okay, nakita nyo na yung sagot. The correct answer is DNA ligase. Let me just explain. So what is this? If you see these types of question, no, that requires you to analyze a bit. So normally though, at 32 degrees, all the enzymes are functioning. So remember, if all the enzymes are functioning, then you will have, at the end of DNA replication, you have 2 identical DNA molecules, correct? So semi-conservative. So both of them containing the parent strand and the daughter strand. Then what happened? When you raise the temperature from 32 to 42 degrees, there's an enzyme that will malfunction. Maybe because it will no longer tolerate the higher temperature. So what happened now? So what happened was that when you raise the temperature, the DNA, instead of 2 identical DNA molecules, the other one, the DNA will be short segments, meaning to say, hindi sila dikit-dikit. So what does that mean? Which one did not work? So the correct answer there will be DNA ligase. Why? It means that after replication, so you see, diba, when you go back to DNA replication, right, when you're almost complete, DNA ligase is supposed to seal, no? DNA ligase is supposed to seal the final nick. So if there's no DNA ligase, then what happens then? the fragments, no, they will have short fragments of DNA. Okay, so try to imagine what will happen try to imagine what will happen to your DNA if the enzymes are not functioning. So for example, if DNA polymerase 1 is not working, what will happen? No? So what does DNA polymerase 1 do? No, DNA polymerase 1 removes the RNA primers. So what will happen is that you will have RNA in the DNA. You will have RNA in the DNA. Or what if topoisomerase is not working? Okay, so think of those scenarios. No, what if helicase is not working? So ganun lang yun. That's how you approach those cases. Number 55, a young male patient was brought to the emergency department because of severe muscle pains throughout his body, which started after he exercised vigorously. He had two similar episodes years before. CBC showed anemia and peripheral smear revealed odd-looking RBCs that resembled an elongated sausage rather than concave discs. Which of the following mutations will explain his findings? Deletion, insertion, missense, or nonsense? A young male patient was brought to the emergency department because of severe muscle pains throughout his body, which started after he exercised vigorously. He had two similar episodes before. CBC showed anemia and peripheral smear, odd-looking red blood cells that resembled sausage. So what's the diagnosis here? So the diagnosis here is sickle cell anemia. So if you have sickle cell anemia, what's the mutation? So the mutation is a missense, no? So if you remember, look, in sickle cell anemia, this is normal below. So it's supposedly GAG. It became GTG. So from glutamate, it became valine, no? So the codons for the sixth amino acid in the beta globin chain. So remember this, sixth amino acid in the beta globin chain. No, that's where the missense mutation is found. No, so sometimes they ask this. So glutamate to valine, no, sixth amino acid in the beta globin chain. So you change the amino acid. That's why it's a missense mutation. Question number 56. A 24-year-old patient with multiple sexual partners presents with purple plaques and nodules in the arms and legs. The patient also has oral thrush and chest findings compatible with pneumonia. If the screening tests were positive, which of the following would confirm your diagnosis? Northern blot, polymerase chain reaction, southern blot, western blot. A 24-year-old patient with multiple sexual partners presents with purple plaques and nodules in the arms and legs. The patient also has oral thrush and chest findings compatible with pneumonia. So what's the diagnosis here? This is probably HIV. No? So the screening test is your ELISA. And how do we confirm ELISA? It's the ELISA via western blot. So please remember this, no? If you're doing a southern blot, so if a western blot, what are you analyzing? You're looking for proteins. So when you do the western blot, it means you're looking for the HIV proteins, the surface proteins, the glycoproteins of HIV. If you're analyzing DNA, then you use southern blot. If you're analyzing RNA, northern blot. So snowdrop, no, the mnemonic there is snowdrop. No, if you're analyzing, so tatingnan nyo lang what are you analyzing. If you're trying to detect antibodies, then that's ELISA, no? Then that's ELISA. Number 57, a 2-week-old infant diagnosed with type 2 hyperanemia had enzyme activity analyzed. There was no activity for the OTC enzyme. The mRNA product of the gene for OTC was identical to that of a control. Which of the following tests was most likely used to analyze the size and amount of the mRNA? So northern blot, southern blot, western blot, polymerase chain reaction. A 2-week-old infant diagnosed with type 2 hyperammonemia had enzyme activity analyzed. There was no activity for the OTC enzyme. The mRNA product of the OTC was similar to that of a control. What was used to analyze the size and amount of mRNA? So because we're analyzing mRNA, so your RNA, since you're analyzing RNA, then it's a northern blot. No? Because you're analyzing RNA. Ganun lang yun, no? So look, no? So since you're analyzing RNA, then it's a northern blot. Number 58. Genetic analysis of a child with beta thalassemia showed that one of his globin genes has a mutation in which a new splice acceptor site is created, 19 nucleotides upstream of the normal splice acceptor site of the first intron. What will happen to the new mRNA molecule because of this mutation? A. Exon 1 will be shorter. B. Exon 1 will be longer. C. Exon 2 will be shorter, or D. Exon 2 will be longer. Genetic analysis of a child with beta thalassemia showed that one of his beta globin genes has a mutation in which a new splice acceptor site is created, 19 nucleotides upstream of the normal splice acceptor site of the first intron. What will happen to the new mRNA molecule because of this mutation? A. Exon 1 will be shorter. B. Exon 1 will be longer. 2. Exon 1 will be shorter. D. Exon D will be longer. The correct answer here is letter D. Exon 2 will be longer. Let's try to explain. Let's try to explain. So when we say this one, so this is the normal protein. So exon 1, intron 1, exon 2, intron 2, exon 3. So which one is important here? The exons. So the exons are expressed, and normally what do you do? So normally you're supposed to remove the introns, no? So normally you're supposed to remove the introns. Okay, so dapat exon 1, exon 2, exon 3 na lang yung matitira. So what did the question say? The question said there's a new splice acceptor site, okay, of the first intron. So yung first intron, so dapat, no? So this is the acceptor, this is the receptor, no? Okay, so ang nangyari, no? So donor and acceptor. So you will see, so correct what I said last, no? So ang nangyari, yung acceptor site ng intron, dapat, no, dito kasi siya i-accept. So dito dapat yung, okay, dito dapat yung splice site. But what happened was, yung splice site, instead na dito is-splice, upstream na siya. So you will see here, okay, naging upstream siya. So anong effect nun? So you will see, because of that, hahaba yung exon 2. Okay, kasi dito yung splice acceptor site. So donor acceptor, donor acceptor, donor acceptor. Sinabi, yung splice acceptor site umakyat. So pag umakyat yon, hahaba si exon 2. That's why, yun yung sagot. Exon 2 will be longer. Okay, exon 2 will be longer. Oops, sorry. Right, next question. Genetic analysis of a child with Duchenne muscular dystrophy showed the mutation in the promoter gene, region of the DMD gene. What is the most likely effect? Sorry, there's already an answer, but let me just explain. So, you have a child, when you say there's a mutation in the promoter region, no? So, if it's in the promoter region, so what part is affected? So, it's initiation, no? So, initiation of transcription will be defective. So, remember, when we say promoter, no, yung promoter, it's important for DNA transcription, yung DNA to RNA. Because remember, what are the steps of transcription? Initiation, elongation, and termination. So in the initiation, no, so that's where the your promoters will be important. Okay, that's where the promoter region of the gene will be infected. It will be important because the promoter will help promote the transcription of the DNA into RNA, and then so that the RNA will be synthesized, or mRNA, and then proteins will be synthesized using this template. So letter A is wrong, no? Because what's capping? Capping of mRNA, that's a post-transcriptional modification. So after you transcribe the mRNA, you can put a methylguanosine cap or a poly-A tail. No? Letter C is also wrong kasi yung splicing, that means it's also a post-transcriptional modification. So after you transcribe mRNA, you can remove different combinations of introns. No? And then letter D, termination of dystrophin transcription will be defective. That's incorrect because termination doesn't have anything to do with promoter. So although this is also transcription, what are the important things for termination? It's the formation of the hairpin loop o kaya Rho factor. No? O kaya Rho factor. Yung letter A, no? So that's why letter B yung sagot dyan, no? Kasi initiation. Kung hindi naman yung promoter region, no? It can also be the sigma factor, which is also important for initiation. Question number 60. A patient was noted to have an abnormal protein that is 180 amino acids instead of 126. Which of the following mutations is consistent with this? A, AUG to UAG, B, GAA to UAA, C, UAA to GAA, or D, UAA to UGA. A patient was noted to have an abnormal protein that was 180 amino acids instead of 126. Which of the following mutations is consistent with this? So ano nangyari? Dapat mahaba, no? So dapat 126 lang. Pero naging 180. So ibig sabihin from stop, naging coding yung amino acid. So alin dito yung stop? So alin dito yung stop? So ito yung letter C or letter D, no? Kasi stop sila dapat. Okay, instead of stop, naging coding. So mali na eliminate na natin yung A at B. AUG, that's the first amino acid, naging stop. So baligtad tong dalawa, no? So dapat kung itong dalawa yung nangyari, dapat iikse. Pero ang nangyari sa amino acid natin, humaba. Kaya from stop, naging coding. So from ito, yung letter D, stop, naging stop. So dapat no change. Ito stop, naging coding, no? So stop, naging coding. So this is the correct answer, letter C. Question number 61. A blood sample is taken from a patient after eating spaghetti and fried chicken. Which of the following will be at a higher concentration than if the blood were taken after an overnight fast? Alanine, glucagon, glucose, ketone bodies. A blood sample is taken from a patient after eating spaghetti and fried chicken. Which of the following will be at a higher concentration than if the blood were taken after an overnight fast? Alanine, glucagon, glucose, or ketone bodies. So here, what's the question? No? So don't overthink. So you got the patient at what state? So after eating spaghetti and fried chicken. So ibig sabihin, you're being asked to compare kapag well-fed versus fasting. So alin daw yung mas mataas when you are well-fed compared to when you are fasting? So what's the best answer? Of course, glucose, no? So because when you are well-fed, you have higher levels of glucose compared to when you're fasting. Glucagon, this is incorrect because, glucagon is higher when you're fasting. Same with ketone bodies, no? Same with ketone bodies. There may be a transient rise in alanine, but actually, it will be much higher. It will be higher, no? It's the best answer here is glucose. Now, let's do the same thing. Number 62. A blood sample is taken from a patient after an overnight fast. Which of the following will be at a higher concentration than if the blood were taken after a meal? So ito binaligtad lang, no? So glucose, insulin, non-esterified fatty acids, triacylglycerol. A blood sample is taken from a patient after an overnight fast. Which of the following will be at a higher concentration than if the blood were taken after a meal? So after fasting. So alin daw, pero which one daw will be higher when you've just eaten? So is glucose higher when you're fasting? No. Is insulin higher when you are fasting? No. Are non-esterified fatty acids higher when you're fasting? Yes. Ano ibig sabihin ng non-esterified fatty acids? These are fatty acids that are not attached to glycerol. So remember when you're fasting, what happens? Ginugupit natin yung triglycerides, no? We using hormone-sensitive lipase, we liberate the fatty acids from the glycerol backbone. That's why non-esterified fatty acids will be higher. Triacylglycerol will not be higher when you're fasting. Triglycerides will be higher after a fatty meal. Number 63. A blood sample is taken from a patient after fasting for 1 week, drinking only water. Which of the following will be at a higher concentration than if the blood were taken after an overnight fast? Glucose, ketone bodies, non-esterified fatty acids, triacylglycerol. A blood sample is taken from a patient after fasting for 1 week, drinking only water. Which of the following will be at a higher concentration than if the blood were taken after an overnight fast? Glucose, ketone bodies, non-esterified fatty acids, or triacylglycerol. So what are we trying to compare here? Day 1 of fasting versus day 7 of fasting. So alin daw yung mas mataas when after on the day 7th day of fasting? The correct answer is ketone bodies. So remember the graph I showed you before. No, as you prolong fasting, then ketone bodies will be much higher. Number 64, a blood sample was taken from a patient 1 to 2 hours after eating chicharon, crispy pata, and lechon kawali. What a fatty meal. Which of the following will be elevated? Chylomicrons, HDL, ketone bodies, VLDL. A blood sample was taken from a patient 1 to 2 hours after eating chicharon, crispy pata, and lechon kawali. Which of the following will be elevated? Chylomicrons, HDL, ketone bodies, VLDL. So remember, when you eat a fatty meal, they will be absorbed in the intestines, specifically in the terminal ileum. No? So what will happen? What will transport them from the ileum, from the intestines, to the peripheral tissue? Which lipoprotein? The correct answer is chylomicrons. No? So remember, the chylomicrons, their duty is to transport dietary lipids. Yun yung ruta nila. Okay? So the other thing, so you will see here, no? So this is the route of chylomicron. So look, from the intestines, you see you have your dietary lipids, triglycerides, and cholesterol. They are brought to the peripheral tissue. And then the chylomicron remnant goes back to the liver. So the other thing they always like to ask about your lipoproteins, which one has the highest protein content? HDL. Which is the highest lipid content? Chylomicron. Which is the highest cholesterol content? LDL, which is the biggest diameter? Chylomicron. No? So remember these things, no? Yung mga very highest, lowest. No? Number 65, a blood sample was taken from a patient 4 to 5 hours after eating chicharon, crispy pata, and lechon kawali. Which of the following will be elevated? Chylomicron, HDL, ketone bodies, VLDL. So fatty meal din ulit, but now we're talking 4 hours after a meal. So remember, majority of fatty acid synthesis happens in the liver. And then the liver now has to export those lipids and triglycerides. So what will be used to export those triglycerides and cholesterol? It's VLDL. No? VLDL. Okay, so same thing. Number 66. Which of the following will have the highest glycemic index? Green mango, mango juice, mango pie, boiled kamote. Which of the following will have the highest glycemic index? Green mango, mango juice, mango pie, boiled kamote. So when you say glycemic index, how much does your serum glucose go up compared to your standard, which is glucose? So after a meal, so of course, which one will be very sweet, will have high amounts of glucose? It will be mango juice. So remember, what you want are low glycemic index foods, because the low glycemic index, they don't promote the insulin spike, which is bad for you. No, they don't promote the insulin spike. So the more sustained, gradual elevation of glucose, and then it gradually goes down. You don't want high glycemic index foods, such as white bread or bagel, no? So yung mga sugars, no? Yung mga sugars na hindi masyadong madaling ma-digest, no? Yung mga masyadong madaling ma-digest at ma-absorb. Let's do the opposite. What will have the lowest glycemic index? So of course, obviously, it's boiled kamote. Number 68, healthy volunteers were fed mixtures of amino acids as their only protein source. Which of the following diets will lead to negative nitrogen balance, assuming that all other amino acids are provided in adequate amounts? A, mixture lacking alanine, aspartate, and glutamate. B, mixture lacking alanine, glycine, and tyrosine. C, mixture lacking asparagine, glutamine, and cysteine. D, mixture lacking lysine, arginine, and tyrosine. Healthy volunteers were fed mixtures of amino acids as their only protein source. Which of the following diets will lead to negative nitrogen balance, assuming that all other amino acids are provided in adequate amounts? So what is this question essentially asking? No? So why will we get negative nitrogen balance? We will get a negative nitrogen balance. Ibig sabihin, we are not able to synthesize we're not able to get the proteins that we need. No? So, for example, if you're eating a protein mixture that will not have alanine, glycine, and tyrosine, is that a problem? No, why not? because we can synthesize alanine, we can synthesize glycine, and we can synthesize tyrosine. So even if you don't get them from the diet, you'll be fine. Okay? So essentially, you're trying to look for the mixture no, na may lacking amino acids na essential, because if those are not in the diet, then you cannot synthesize them. And the correct answer is here, letter D. Because if you do not have lysine and arginine, you will not be able to synthesize them. No? So always argues. So arginine, even though we can produce it in the body, it's not enough. So we have to get it from the diet. Lysine, we have to get it from the diet kasi private team hall. No? Tyrosine, okay lang. We can synthesize that from phenylalanine, but these two, hindi. Number 69, an alcoholic was found unconscious near a local bar and was taken to the emergency department where laboratory tests showed a blood glucose level of 40 milligrams per deciliter. To confirm the most likely vitamin deficiency in this patient, which diagnostic assay should you order? A. Erythrocyte transaminase assay. B. Erythrocyte transketolase assay. C. Figlo excretion test. Or D. Schilling test. An alcoholic was found unconscious near a local bar and was taken to the emergency department where laboratory tests showed the blood glucose level of 40 milligrams per deciliter. So he's hypoglycemic. To confirm the diagnosis, what will you order? So, of course, we know the diagnosis here is, okay, what's a deficiency? This is probably, Wernicke-Korsakoff. This is probably chronic alcoholism. Okay, so if you're in chronic alcoholism, you have vitamin B1 deficiency. And vitamin B1 is diagnosed by the transketolase assay. Why? Because your transketolases, remember, saang pathway sila? Sa pentose phosphate pathway second phase. And that second phase will require thiamine. What about transaminase assay? Transaminases will require B6 pyridoxal phosphate. So that's why you use transaminase assay to diagnose B6 deficiency. In Figlo excretion test, you ask the patient to ingest an oral load of histidine, and then you try to measure formiminoglutamate in the urine. So this is for folate deficiency. Schilling test, para sa ng Schilling test, diagnosis vitamin B12 deficiency. Number 70, over the past 3 months, a patient excluded all meat, egg, legumes, nuts, and seeds from her diet. She takes a protein supplement, but not a vitamin supplement. What will be impaired in this patient? A. Absorption of amino acids in the intestines. B. Production of urea by intestinal bacteria. C. Production of uric acid. D. Transamination of amino acids. Over the past 3 months, a patient excluded all meats, eggs, legumes, nuts, and seed from her diet. She takes a protein supplement, but not a vitamin supplement. Which of the following will be impaired in this patient? So you see here, you take a protein supplement, but not vitamins. So you will see, no? So, which vitamin will she not be able to get? No? She will not be able to get vitamin B6. No? She will not be able to get vitamin B6, pyridoxal phosphate, if you do not eat any of these. So which among the choices, which will require vitamin B6? Sabi natin yung vitamin B6 are required in amino acid reaction. So the answer is letter D. The answer is letter D. Letter A is incorrect because absorption of amino acids just relies on co-transport with sodium. Letter B, production of urea, not related as well. Production of uric acid, not related. A medical student trying to lose weight is doing intermittent fasting with his last meal at 6 p.m. every day. He does not eat anything until 8 a.m. the next day. The following are observed except at 6 a.m. So 6 p.m. siya huling kumain. So at 6 a.m., that's 12 hours after the meal, no? 12 hours after the last meal. Will he, letter A, will he increase gluconeogenesis? So remember, no, in the fasting state, do you want to create new glucose? Yes. No? Letter B, increase lipolysis. Do you want to burn your fat when you're fasting? Yes. Letter C, do you want to synthesize proteins? No, no. Instead, you will break down protein. So that's the correct answer. You will convert your proteins to glucose. Letter D, increase glycogenolysis. Will you break down your glycogen into glucose? Yes, that's also correct. That's why letter C is the correct answer. Number 72, a medical student started a ketogenic diet. For lunch, he ate eggs, bacon, and greens with olive as dressing. The following are expected, except, right? So remember, in the ketogenic diet, what do? You eat a lot. You don't eat carbohydrates. You replace it with protein and fats. No, you replace it with protein and fats. So A, gluconeogenesis is activated because you're not eating carbohydrates. You will try to create glucose. Is that correct? Yes, that's correct. So letter A is correct. No? So you will try to create glucose. B, lipolysis is inhibited. Wrong. That's the one that's incorrect. No, in fact, lipolysis will be activated. So that's why you lose weight from a ketogenic diet. You burn fat. Why do you need to burn fat? You need to burn fat because beta oxidation will provide the energy for gluconeogenesis. So without beta oxidation, you will not be able to create new glucose. So essentially, so again, what happens in a ketogenic diet? You're not eating carbohydrates. But because some of your organs need glucose, you will create glucose even if you're not fasting. So you will undergo gluconeogenesis. But to undergo gluconeogenesis, you need to burn fat, lipolysis. So that's what causes the weight loss. So letter C, acetoacetate and beta hydroxybutyrate will be elevated compared to the person on a normal diet. So yeah, that's expected. No, kaya nga siya ketogenic diet. So it will not be much higher than ketosis. Hindi naman siya ketosis levels, no? But you will have ketogenesis. Kasi nga hindi ka kumakain ng carbohydrates. You're burning down fat. You're burning fat. Letter D, insulin will be decreased compared to a person on normal diet. That's correct. Because on a ketogenic diet, because you're not eating carbohydrates, you will not have insulin spikes associated with high glucose levels. Number 73, a medical student about to take the board exam had hot chocolate and pandesal at 6 a.m., after which he was not able to eat anything else throughout the day. So don't follow this example. You need to eat. No sugar. If there's no glucose, you will not be able to think. Which of the following pathways is expected to primarily maintain his blood glucose level at 4 p.m.? Glycogenolysis, gluconeogenesis, beta oxidation, ketogenesis. A medical student about to take the board exam had hot chocolate and pandesal at 6 a.m., after which he was not able to eat anything else. Which of the following is expected to primarily maintain his glucose levels at 4? So from 6 a.m. to 4 p.m., how many hours is that? That's 10 hours. So 10 hours after a meal. Will you be undergoing glycogenolysis? Yes, so that's the correct answer. So remember, for the first 4 hours, it is the glucose that you ate. And then from 4 hours to 18 or 24 hours, you will break down glycogen. You will break down glycogen. So that's what provides you your, so that's what we will provide you with glucose. And then after 24 hours, once you've consumed your glycogen stores, then that's when you undergo gluconeogenesis. So that's why here, so 6 a.m. ka na nagising, because of fatigue, the medical student just slept after going home without eating anything. So 6 a.m. the next day, what will be maintaining his blood glucose? So this is already at 24 hours, and it will be gluconeogenesis already. Because at this point, you no longer have glycogen stores. So do you remember what are the 4 substrates of gluconeogenesis? So let number 1, all intermediates of Krebs cycle and glycolysis except acetyl-CoA. Number 2, lactic through Cori cycle. Number 3, glucogenic amino acids. Number 4, glycerol and propionyl-CoA. From there, triglycerides. Question number 75. After taking the board exam, a medical student went straight to Jollibee and ordered C3, Jollibee plus Chicken Joy. Large Coke, more sauce, extra rice, plus peach mango pie. After the meal, the following will be observed except A, fructose 1,6-bisphosphatase is phosphorylated. B, glycogen synthase is activated. C, HMG-CoA synthase is inhibited. D, hormone-sensitive lipase is dephosphorylated. So after taking the board exam, you ordered C3, large Coke, more sauce, extra rice, peach mango pie. The following will be observed except. So let's try to analyze. So what's the first thing you need to do when you encounter these questions? Step number 1, don't panic. Hingang malalim. Okay, so to be honest, what's the easiest to eliminate here? No, yung phosphorylation tsaka dephosphorylation, di ba? I told you, yan yung pinakamadali. Why? Where are we talking about the well-fed or fasting state? We're talking about the well-fed. So kung well-fed, WF, walang phosphate. So you already know, letter D is correct. Kasi hormone-sensitive lipase is dephosphorylated. Walang phosphate. And you already know letter A is wrong. Kasi nga dapat dephosphorylated. Ay, ganun lang kadali yun. No? So when you're well-fed, the enzymes must be dephosphorylated. When you're fasting, the enzymes must be phosphorylated. We know that letter B is correct. So in the well-fed state, do you want to activate glycogen synthase? Do you want to synthesize glycogen? Yes. Do you want to inhibit HMG-CoA synthase? Or remember, what is HMG-CoA synthase for? It's for ketogenesis. Will you create ketone bodies when you're well-fed? Of course not. Number 76, elevated homocysteine is associated with deficiency of which of the following? A, ascorbic acid. B, cobalamin. C, niacin. D, tocopherol. Elevated homocysteine is associated with deficiency of which of the following? Ascorbic acid, cobalamin, niacin, tocopherol. So the correct answer here is cobalamin. So remember, no? So, okay, vitamin B12, no? So you will see, so if you have elevated homocysteine, no? So you have elevated homocysteine, it means hindi mo siya ma-convert to methionine. So kung wala kang B12, no? Kung wala kang B12, you will not be able to convert homocysteine to methionine. So you need B12 to lower homocysteine levels. Okay? You can use B12 to lower homocysteine levels. Number 77, a 3-year-old boy has episodes of skin rashes that spontaneously resolves in a week or so. The parents were advised by the pediatrician to give him niacin and a high-protein diet every time this occurred. They shortened the symptoms to 1 to 2 days. What's the most likely diagnosis? Cystinuria, heart-nump disease, Menkes disease, Wilson disease. A 3-year-old boy has episodes of skin rashes that spontaneously resolve in a week or so. The parents were advised by the pediatrician to give him niacin and a high-protein diet every time this occurred. This shortened the symptoms to 1 to 2 days. What's the most likely diagnosis? So rashes, no, symptoms yan ng diarrhea, dermatitis, dementia, di ba? Sa pellagra. So what's the deficiency here? Okay, the deficiency here is vitamin B6, no? So the patient has vitamin B6 deficiency. And the reason for this is heart-nump syndrome. So in heart-nump disease, you are unable to absorb tryptophan. No? So since you are unable to absorb tryptophan, you don't have the building blocks for niacin. No, you have the building blocks for niacin. Okay, so tandaan nyo, in heart-nump disease, you cannot absorb tryptophan. Tryptophan is the precursor for niacin. Number 678, methotrexate toxicity mimics which of the following vitamin deficiencies? Biotin, folate, pyridoxine, thiamine. Methotrexate mimics which of the following deficiencies? Biotin, folate, pyridoxine, thiamine. So methotrexate, what does methotrexate do? Methotrexate is a folate inhibitor. So you will see the correct answer there is folate. So folate deficiency. So remember, methotrexate inhibits dihydrofolate reductase, which converts folate to dihydrofolate and dihydrofolate to tetrahydrofolate. So if you do not remember, tetrahydrofolate is the active form. You need tetrahydrofolate. So if folate is not converted to tetrahydrofolate, then it will not be useful in transferring 1 carbon units. So for example, here, shows here, 5-fluorouracil, another chemotherapeutic agent, which inhibits thymidylate synthase, preventing synthesis of thymine. So kung walang tetrahydrofolate, wala ring activity yung tetraentymidylate synthase. Number 79, vitamin B12 deficiency leads to trapping of folate in which form? A. Dihydrofolate, B. N10-formyl tetrahydrofolate, C. N5-methyl tetrahydrofolate, or D. N5-N10 methylene tetrahydrofolate. Vitamin B12 deficiency leads to trapping of folate in which form? So the correct answer here is letter C. Ano ba ibig sabihin ng folate trap? So here, so your folate, I told you earlier, no? So yung folate, so here, folate, you need to convert it to tetrahydrofolate. So see this one? So you need to convert your folate to tetrahydrofolate for it to become useful. So you will see here, take note here, N5-methyl tetrahydrofolate. Sometimes it is converted to N5-methyl tetrahydrofolate. This is useless. No? So N5-methyl tetrahydrofolate, this is useless. You cannot use this. Para maging useful siya, you need homocysteine, so you need methionine. You need B12. See this? So for N5-methyl tetrahydrofolate to become tetrahydrofolate again, you need B12. So what will happen if you do not have B12? All the folate will be trapped here. No? So all the folate will be trapped here. It cannot be converted to tetrahydrofolate. It will not have any use. So that's why a B12 deficiency can lead to B6 deficiency, even though you actually have not B6, but folate. Even though you actually have high levels of folate. It's just that they're all being trapped as N5-methyl tetrahydrofolate. So that's functional folate deficiency. How do you differentiate folate deficiency and from B12 deficiency? Both of them have megaloblastic anemia. So remember that B12 deficiency will have neurologic deficits, specifically subacute combined degeneration. Number 80, a patient who ingests 20 raw eggs per day will be expected to have elevated levels of malonate, methyl malonate, oxaloacetate, propionate. A patient who ingests 20 raw eggs per day will be expected to have elevated levels of malonate, methyl malonate, oxaloacetate, propionate. So just remember, 20 raw eggs will contain avidin, and avidin will inhibit absorption of biotin. So what are the biotin requiring reactions? Your carboxylases. So which one of these is a substrate for a carboxylase? It is propionate. So remember, propionyl-CoA carboxylase converts propionyl-CoA to methyl-malonyl-CoA. Letter B is wrong because methylmalonic acid, methyl-malonyl-CoA to succinyl-CoA, the enzyme there is methyl-malonyl-CoA mutase. So, okay, oxaloacetate is also wrong because it's pyruvate to oxaloacetate. So pyruvate carboxylase, it is pyruvate that will go up, no? Not oxaloacetate. Number 81, a 6-month-old infant was brought to a pediatrician because of rashes and hair loss. She was exclusively breastfed until 3 months and was weaned thereafter. On examination, the infant had plaques with scaling and crusting on her perioral region, cheeks, scalp, perineal area, scalp, hands, and feet. She had very sparse hair. She had a low birth weight for age, and her mother reported that she frequently had watery stools, the serum level of which nutrient is most likely to be deficient: copper, iron, manganese, zinc. So you see here, what's the buzzword here? No? So it's the sparse hair. No? So sparse hair with rashes. So sparse hair with rashes. So take note, zinc deficiency yan. Okay, so very characteristic of zinc deficiency. So zinc deficiency presents with dermatitis, diarrhea, and alopecia. No? So dermatitis, diarrhea, and alopecia. So about 20% of patients with zinc deficiency will have this. So if you see that, so remember, diarrhea, dermatitis, and alopecia, think zinc deficiency. Number 82, a 35-year-old female consulted a neurologist because of flapping tremors of both upper limbs associated with unsteady gait and slurring of speech. On examination, a brown discoloration was noted at the outer margin of both corneas. Serum ceruloplasmin was low at 4 milligrams per deciliter. What's the most likely diagnosis? Menkes, Wilson led hemochromatosis. 35-year-old female consulted a neurologist because of lamping tremors of both upper limbs associated with unsteady gait and slurring of speech. On examination, a brown discoloration was noted at the outer margin of both corneas. What's the most low ceruloplasmin level? What's the diagnosis? So yung brown discoloration at the outer margin of both corneas, those are your Kayser-Fleischer rings. Okay, Kayser-Fleischer rings. So you see, you have neurologic deficits, Kayser-Fleischer rings, low ceruloplasmin. The correct answer is Wilson. So in Wilson disease, no, the problem is accumulation of copper. No, so accumulation of copper, that's Wilson disease. Number 83, an infant was referred for evaluation of intractable seizures. On examination, the baby was microcephalic with coarse facial features. Laboratory workup revealed elevated levels of xanthine and hypoxanthine. What mineral is most likely to be deficient? Copper, manganese, selenium, molybdenum. An infant was referred for evaluation of intractable seizures. On examination, the baby was microcephalic with coarse facial features. Elevated xanthine and hypoxanthine. What is deficient? So the correct answer here is molybdenum. So remember, molybdenum is a cofactor of xanthine oxidase. No? That's why xanthine and hypoxanthine will be high. So xanthine oxidase requires molybdenum. Number 84, a neonate was noted to have poor cry and poor activity during its first few days of life. Laboratory testing shortly after birth showed markedly elevated bilirubin levels, 42 milligrams per deciliter. What's the most likely diagnosis? A. Crigler-Najjar, B. Dubin-Johnson, C. Gilbert, or D. Rotor syndrome. A neonate was noted to have poor cry and poor activity during its first few days of life. Laboratory testing shortly after birth showed markedly elevated bilirubin levels at 42 milligrams per deciliter. What's the most likely diagnosis? Crigler-Najjar, Dubin-Johnson, Gilbert syndrome, Rotor syndrome. You know what the clue here is? Elevated bilirubin, no? So unconjugated bilirubin. And then first few days of life. So the correct answer here is Crigler-Najjar. So the problem with Crigler-Najjar, you cannot conjugate bilirubin to the glucuronic acid. So indirect hyperbilirubinemia, this is fatal if not treated. No? So the cure here is liver transplantation. Finally, number 85, a 6-year-old child was referred for evaluation of jaundice. This was not associated with pruritus, abdominal pain, or drug intake. Laboratory testing revealed mixed conjugate and unconjugated hyperbilirubinemia with total bilirubin 4 milligrams per deciliter, so not so high. Elevated coproporphyrin in the urine. Liver biopsy was not performed. What's the most likely diagnosis? So same choices. Crigler-Najjar, Dubin-Johnson, Gilbert, or Rotor syndrome. 65-year-old child was referred for evaluation of jaundice. It was not associated with pruritus, abdominal pain, or drug intake. Laboratory testing revealed mixed conjugated and unconjugated hyperbilirubinemia. With elevated coproporphyrin in the urine, liver biopsy was not performed. What's the most likely diagnosis? So the answer here is Rotor syndrome. So your Rotor syndrome, it's benign. It does not require any therapy. No? So however, how do we distinguish them? No? So how do we distinguish Rotor syndrome from Dubin-Johnson? So ito, yung Dubin-Johnson, Gilbert, tsaka Rotor. No? So magkakapareho sila. So remember, for hyperbilirubinemias, it can be unconjugated hyperbilirubinemia. No? So your Gilbert and Crigler-Najjar. No? So your Gilbert and Crigler-Najjar, there will be unconjugated hyperbilirubinemia. Pag conjugated, you have your Rotor syndrome and Dubin-Johnson. So you see here, how do you differentiate Gilbert, Dubin-Johnson, and Rotor? So you will see for Gilbert syndrome, the predominant will be unconjugated bilirubin. So kapag Dubin-Johnson, conjugated, unconjugated almost equal. So as in this case, medyo mataas ng konting conjugated. So sa histology, Dubin-Johnson, buzzword dyan, pigmentation, black liver. So Dubin-Johnson, black liver. And then, unique sa Rotor, elevated coproporphyrin. Elevated coproporphyrin. Natandaan na, So sa Gilbert, unconjugated hyperbilirubinemia. Sa Dubin-Johnson, black liver. Sa Rotor, coproporphyrin. All of them are benign. All of them are benign. No? So you have different precipitating factors. Most of the time, you know need to treat. So that's the last question. I will leave you with this slide by Paul Kalanithi. So he's a neurosurgeon who wrote the book When Breath Becomes Air, one of my favorite books. I still read it from time to time. He says there are patients' lives and identities may be in our hands, yet death always wins. You can't ever reach perfection, but you can believe in an asymptote towards which you are ceaselessly striving. So you see, always give it your best shot. No? So always, no. So that's why he says, I believe in an asymptote. Always just give it your best. No, give it all that you can. No. Give it all that you can. I know sometimes it feels like this. The odds are not in our favor, heart. No. So, but what did heart say? That will make it feel even better when we win. No, that will make it feel even better when we win. So I know that I wasn't able to meet most of you, the majority of you in person. But I'm really thankful for this opportunity to be able to be part of your journey towards getting that license. If at some point we see each other, whether in the hospital, in school, or in the mall, or wherever, just say hello. Just say hello. No, so just say hello. And I would be very happy to congratulate you, doctor. Okay, take care.